среди них 15,6% от дисфункции графта и 2,2% на начальных этапах, то 13,3% этих пациентов умирали из-за отсутствия компонентности. То есть они отказывались от приема, некоторые пациенты отказывались от приема препаратов, какие-то пациенты не выполняли назначение врача и, соответственно, позднее обращение. На этапе развития мы имели летальность в 4,4%, и в основном это билиарное осложнение, как и дисфункция графта, также на фоне отсутствия компонентности. И здесь мы хотели показать сводные результаты программы родственной трансплантации. На начальном этапе у нас остались живы всего 62,7% пациентов, тогда как госпитальная летальность составила 23% и отдаленно 13%. А на этапе развития среди 154 пациентов фактически 90% наших пациентов живут. Госпитальная летальность составила 61% и отдаленная летальность 4,4%. И я коротко, если можно, быстро остановлюсь. На сегодняшний день мы стали внедрять попытаемся внедрить адаптированный раз-протокол под трансплантацию живого донора. Нами последние 24 трансплантации проходило по адаптированному протоколу ИРАС. Однако надо сказать, что протокол ИРАС требует адаптации, так как трансплантация печени имеет большое количество билиарных сосудистых осложнений. Также пациенты, как правило, обращаются с выраженной саркопенией, коагулопатией, нарушением декомпенсированностью органов. Поэтому нами был предпринят мягкий подход к переходу к этому протоколу. Он подразумевает 4 этапа. Первый – это предоперационная подготовка. Предоперационная подготовка подразумевает подготовку пациентов, семьи, докторов и медперсонала к переходу к ИРАС. Именно нутриционная подготовка пациентов на догоспитальном этапе, то есть борьба с саркопенией. Реабилитация, так называемая start low, go slow, вирусологическая подготовка пациентов. Следующий этап – это интероперационная, подразумевает применение мультимодальной анальгезии с опиоидами, контроль динамических параметров и ЦВД, нормометрия и сокращение потери крови интероперационно. Послеоперационный этап подразумевает у нас передислокацию пациента из реанимации в попытке передислокации на первые сутки после операции, интервальную поддержку питания фактически с первых суток и раннее удаление дренажей, мониторинг гемостаза, гемостатический и кровотока. Ну, естественно, клинический аудит. Надо иметь в виду, что переход к ИРАСу должен быть мягкий. То есть во многих клиниках мира трансплантологических сейчас идут попытки перехода к этой программе. Но главное при этом не попытка быстро выписать пациента и поднять его на ноги, а сохранение графта и, главное, гемостаз у этих пациентов. Здесь вот мы хотели показать, как все это изменилось. Ну, это пока предварительные результаты и обнадеживающие.
Ренат Равильевич, время.
Все, спасибо большое. Вот наши показатели. Спасибо большое.
Рахмат. Спасибо вам большое. Пожалуйста. Mikrofon verin. Birinci karar. Birinci redki.
Renat, thank you for your nice and good presentation. I have a lot of many questions, but I will give you only two. First question. I saw that you said the hepatitis B and D incidence in your country is very high, around 80%. It is very, very high. Can you explain why it is very high, this combination in your country? And second question, do you have governmental center, coordination center in Uzbekistan? Coordination center for transplantation.
Thank you for your question. I can answer in Russian. Да, эндемичность по гепатиту Б и дельта в Узбекистане достаточно высокая. У нас даже в 2019 году совместно с Центром вирусологии проведено такая ЭРАС и Центр ИЗО, то есть Европейская ассоциация, проводила исследования. И они показали, что среди фактически 62% носителей вирусного гепатита Б имеют дельтавирус в Узбекистане. Соответственно, и циррозом достаточно быстро приходит. Дельтавирус приводит к циррозу печени порядка около 5 лет. В том-то его проблема. Эндемичность, скорее всего, связана с тем, что в какой-то момент были какие-то нарушения, скорее всего, мне кажется, ранее. Стерилизации, я думаю, были проблемы со стерилизацией в тот момент. И, естественно, развитие этих вирусных гепатитов стало достаточно распространенным. На данный момент у нас имеется программа по вирусному гепатиту Б и по вирусному гепатиту С. То есть препараты раздаются фактически пациентам бесплатно со стороны. Однако дельта-вирус, как вы знаете, пока не имеет доказанных препаратов, которые могут вылечиться. Единственным радикальным методом является трансплантация печени. В этой ситуации я так думаю, что в свое время когда-то были проблемы именно со стерилизацией медицинского оборудования. Тогда было заражено много пациентов. И в ответ на ваш второй вопрос, если у нас координационный центр, закон Республики Узбекистан разрешает трупную трансплантацию. Мы имеем право делать трупную трансплантацию. Однако на данный момент мы имеем большое количество этических проблем с этим. И трупная трансплантация в нашей стране сейчас функционирует презумпция несогласия. То есть пациенты не имеют, любой пациент только сам тогда, когда он живой, он должен пойти к нотариусу и написать, что он хочет стать донором. И только тогда он может стать донором, получив как бы смерть мозга. Таких ситуаций у нас не возникает. Поэтому трансплантации мы планируем сейчас координационный совет какой-то сделать по трансплантации, но мы его не имеем. Он имеет смысл только при трупной трансплантации. То есть каждый центр планово госпитализирует пациента и выполняет эти операции. Но на данный момент работы в этом направлении ведутся совместно с Минздравом, Кабинетом министра и аппаратом президента.
Please.
Профессор Мамедов, Азербайджан. У меня два вопроса к вам. Значит, вы в своем выступлении отметили, что от живых доноров осложнений бывает больше, чем от трупов. Вы проводили какой-то ретроспективный анализ того, почему эти осложнения чаще встречаются от живых доноров? Потому что уровень гистосовместимости от живых доноров выше, чем, допустим, от трупов. И второй вопрос. Были ли какие-то осложнения у живых доноров, которые давали, допустим, свою долю печени, и какие они были? И были ли смертные случаи среди этих доноров?
Различия в трупном и живом донорстве достаточно серьезные. То есть при трупном донорстве вы пересаживаете целый орган. Вы имеете крупные сосуды, вы имеете крупные билиарные протоки. То есть вы фактически можете иметь проток прям с частью кишечника, либо даже те же сосуды от аорты отрезать и выбрать себе достаточно удобный момент. При родственном донорстве проблема достаточно большая. То есть вы должны взять полоргана, не полоргана, 60% органа у родственника, при этом сохранить его функционирующую левую долю. То есть безопасность донора на первом месте. И, как правило, вы работаете с короткими сосудами, с короткими билиарными протоками. И нарушается кровоснабжение этих протоков в том числе. Да, короткое время холодовой ишемии. Это плюс в этой ситуации. Однако диаметр и калибр сосудов новоукладываемых определяет ваше последующее осложнение. То есть одно дело пришить 6-миллиметровых оледок, другое дело 2-миллиметровый проток. Соответственно, вы получаете большое количество осложнений билиарда. Это именно анатомические моменты. Есть ряд исследований, я в слайде в одном показывал, имеется около 10 там разных перспективных исследований даже на 6 тысяч доноров, которые показывают, что отношение шансов возникновения билиарных осложнений у пациентов после родственного донорства фактически двукратно повышается, а билиарных ликеджей, bile leakage, фактически трехкратно. Сосудистые где-то на равных количествах, так как все-таки крупные. И здесь в основном бич – это ахиллова пята всей трансплантологии, именно родственные, это билиарное осложнение, к сожалению. Что касается вашего второго вопроса, да, несомненно, при любых операциях на печени, то есть, как вы как хирург понимаете, при резекциях печени вы имеете какие-то осложнения. В основном, я, к сожалению, вот этот слайд пропустил, у меня были слайды, в котором были показаны осложнения у доноров. В основном у всех этого по донору, у 5 доноров, опять же, с нарушением компонентности, то есть они как бы не соблюдали предписания, были грыжи послеоперационные, была коррекция грыж. У двух пациентов мы имели билиарный leakage, bile leakage, который также функции разрешен был. И в одном случае, к сожалению, пришлось накладывать билиодигестивный анастомоз донору в связи с тем, что был стеноз именно левого протока оставшегося, и это было большой проблемой. Что касается летальности, не буду скрывать, у нас была одна летальность именно... Вот Самаркандский центр в свое время начинал, когда это тогда вот была одна летальность у донора. Тогда было большое разбирательство, и вообще программу это были готовы закрыть в том центре. Но, однако ж, были сложные осложнения и в нашем центре у пациентов. Вот я то, что говорил, обнаружение билирубинной станции. Но, однако, летальный исход подразумевает закрытие программы в целом трансплантации. Поэтому все делается для того, чтобы донор был жив.
Спасибо.
Всё.
Пожалуйста.
Жмите.
Профессор Ахмедов, мы, конечно, сейчас очень внимательно и долго обсуждали о технической стороне этого трансплантации. У меня несколько вопросов. Один вопрос. Какие иммуносупрессивные препараты применяете после операции? Сколько наблюдалось у вас криз отторжения и сколько больных погибли от криза отторжения? И третий еще такой. Кто в Özбекистане первый выполнил трансплантацию органов? Спасибо.
Органов или печени?
Очень.
Понятно. Значит, что касается иммуносупрессионной терапии, вообще в мире подход имеется различные подходы к иммуносупрессии. Так, например, наши индусские коллеги в Корее, они подают трехступенчатую иммуносупрессионную терапию. Мы сторонники двухэтапной, то есть это препараты от акролимуса и именно препараты метилпреднизолона. То есть здесь у нас индукция интраоперационная базиликсимабом, то есть симулектом проходит, а дальше мы ведем пациентов на именно тacrolimus с метилпреднизолоном. Есть тактика такая, в некоторых центрах они также еще используют микофенолат мафетил или мафетиловую кислоту, то есть это СЛС. Криз отторжения. Это имеется в виду, что ранняя дисфункция. Вот первый пациент, которому выполнена трансплантация печени, умер от отторжения в 2018 году. Почему он умер от отторжения? Потому что он перестал пить препараты. Он абсолютно отказался от приема препаратов. Они обратились уже тогда, когда печень просто не функционировала, и пациент умер. Как было сказано, то есть поздние осложнения у нас наблюдались в основном в связи с нарушением компонентности пациентов, то есть невыполнением предписания врача. Ранние дисфункции графтов, как я показал, у нас фактически на первом этапе у 3 пациентов была ранняя дисфункция. То есть вы пересаживаете печень, она просто не работает, и все, и вы ничего не можете с этим сделать. На втором этапе у нас у 4 пациентов, среди 154 пациентов, 4 пациента также отмечалась ранняя дисфункция графта. И если вы имеете в виду как таковой криз отторжения, я видел только 2 раза среди всех этих пациентов. А что касается разных стадий отторжения, хроническое отторжение, острое отторжение, которое коррегируется препаратами, они достаточно часто обращаются. Причем надо понять, что к нам обращаются не только пациенты, оперированные нами. То есть большое количество пациентов оперируются за рубежом, и при наличии осложнения они обязательно приходят к нам, то есть они не едут туда. И это очень большой пул пациентов, которые мы выполняем реконструкции билиарных протоколов после них, билиарные какие-то осложнения, эндоскопические решаем, эндоваскулярно решаем. Вот сейчас обратился пациент с тромбозом фактически воротной вены, приходится делать реканализацию. Или те же самые отторжения возникают, тоже коррекция. То есть здесь вот такая двухсторонняя работа происходит. И первую трансплантацию печени, честно, не вспомню фамилию, но я знаю, что это было выполнено в 1900, по-моему, где-то 35-40... вру. В 72 году, да, выполнено тогда еще, когда... Не вспомню. Честно.
Академик Арипов.
Ухтам Арипов. Да. Ухтам Арипов.
Трансплантация цепочки
Правильно.
выполнил академик Арипов Ухтам Арипович.
Так,
И открыл там отделение трансплантологии.
Да, к сожалению, потом это закрыли.
Первый клинический больниц. Многие товарищи не знают, что Ухтам Арипович является основателями трансплантации в Özбекистане. Извините.
Недавно.
Спасибо.
Спасибо.
Thank you for the Dr. Baybekov.
Question.
Later.
На русском. Намик, доктор, Азербайджан. Спасибо за объемный расширенный доклад. У меня вопрос такой, если я не ошибаюсь, в первой фазе в вашем слайде я заметил recipient right ratio, weight ratio минимально составляет 0,65%. Правильно? Так? Сколько было таких больных, и в результате этих больных хотел бы знать, и почему вы решили, что спуститься, то есть до таких низких цифр.
Спасибо, это очень хороший
И
вопрос.
вообще-то в вашей работе статистически были связь early graft dysfunction and, скажем так,
Ну, small cell синдром, здесь
Да.
синдром малой доли возникает у этих пациентов. Очень хороший вопрос, на самом деле. Почему? Мы специально отметили это, показали эту ситуацию. Здесь, на самом деле, были проблемы с расчетами исходными до операции. Два таких случая. Первое – это наше упущение, то есть когда к нам специалисты, наши радиологи дали объем печени порядка там 650 грамм, грубо говоря, расчетного, оказалось, что он был меньше. И пациента пришлось пересаживать фактически GRV 62 тогда было. Было сложно, был синдром малой доли, пациент 5 дней пролежал в реанимации, однако после стабилизации состояния, насколько мы знаем, с 7 сутков обычно пациент либо умирает до 7 дней, либо не умирает до 7, живет после 7 дней при синдроме малой доли. И вот здесь нам как раз-таки повезло. Он выжил, этот пациент. И второй случай у нас был у пациента, когда мы также, скорее всего, это наша вина, так как мы сделали компьютерную томографию реципиенту, точнее донору, за 4 месяца до операции. У него была жировая дистрофия печени, где-то первой стадии, больше 12% поражены жировой тканью, так называемый жировой гепатоз. Он держал диету, мы его готовили к операции, и при снижении этих показателей подтверждения отсутствия гепатоза мы взяли на операцию. Но, однако, это не повторили. А объемы печени снизились в тот момент, и опять же мы попали в такую же ситуацию. Ну, нам удалось спасти этих двух пациентов, на самом деле. То есть
Спасибо.
я знаю, что минимальный порог – это 0,8. Мы всегда ориентируемся на это. В идеале мы всегда берем единицу, но вот в этих ситуациях вдруг было 0,62.
Тогда я поздравляю вас, это как кейс-репорт вы можете опубликовать.
Готовят, конечно. Спасибо большое.
Спасибо, Ренат Равильевич.
Спасибо большое.
Now let's move on. It's a pleasure to invite Dr. Nasirov, establishing a liver transplantation program for infants under 1 age in the Republic of Uzbekistan, current status, challenges, and solutions.
Насыров.
Dr. Nasirov? Okay, now we pass to the next topic. We wish to...
Okay. Okay.
Айтмайсың мı?
Please, Dr. Nasirov.
Ahmad Gette. Thanks again. Some technical problems. So my presentation also will include many technical problems which we face it. So my name is Mansour. I'm from National Children's Medical Center. I'm one of the part of a very big team who was in charge of pediatric transplantation, and we established the first pediatric, especially infant, the kids under 1 year of age, liver transplants. So infant liver transplant remains the most challenging problem in Uzbekistan. Mostly the biliary atresia, the high indication, but in our center we face a lot of non-biliary atresia indications for pediatric transplantation, especially autoimmune hepatitis, cholestasis, inherited metabolic diseases, which is indicated we're referring them on a very late stage, and this is an indication for liver transplant as well. The goal was develop a stable, high-quality liver transplant program, serving not only in Uzbekistan, but in whole Central Asia. So here you see the part of the team, some snapshots we started. We did the first liver transplant in children 2 years ago. The long-term results is very short, but we are more than happy to share the timetable. So 2020, our center first established it as a structure of pediatric healthcare, and as a pediatric surgery, my base, we did a lot of pediatric surgical cases. And in 2022, we started to think about what kind of help of liver transplant we can do. 2024 first liver transplant. It was not an infant, adolescent. And then we realized that we in need of very high international fellowship training programs, which we faced in. So this is, you see, the first snapshot I did in my center when we arrived from South Korea after my international fellowship. And the team we collected. And our center is now very outstanding in pediatric surgery, a very high renowned center around the world. Current status, so far we did 10 infant liver transplants. We did more than we did 13, but infant age is 10. 72% is biliary atresia. We are only one center who refers to patients with biliary atresia and performing Kasai enterostomy. But again, as I mentioned, according to the, in comparing with other centers, we receive a lot of cases with metabolic liver disease and other indications for liver transplant. So far, 1 year liver survival is 100%, but it's so far, we need 5-10 years. We cannot compare, but our program just started 2 years ago. And of course, the main thing, which was indicated with my colleague in the previous report, living donor, all of them are living donor and 100% of survival, of course. Challenges, what we face it. First of all, the challenge is vascular anastomosis. The vessel is less than 2 millimeters. Size mismatch, GRV. In this case, mostly the kids are very small and even lateral segment is too much for them. And sometimes GRVR can increase more than 5 in these cases. So we have to do something as a reduction or increase the weight of the recipient. Hemodynamics, of course, all of them are unstable and coagulopathy. Learning curve, of course, the learning curve, as I mentioned it, we was in need of international trainings. So what we found the solution is a multidisciplinary training, especially we found that very good matching is Seoul National University and Chinese background, especially Shanghai Renchi Center, one of the highest flow of cases around the world. And of course, the main thing is standardized protocols. Here's a snapshots from Seoul National University Hospital and Professor Lee, one of the famous liver transplant surgeons. I believe everyone who deals with liver transplant knows him. And second challenge is donor availability and logistics. As mentioned before in the presentation, in Uzbekistan, we have only living donor. No, this is donors infrastructure are developed so yet. Donor evaluations, some ethical problems, some cultural problems to evaluate the donors in Uzbekistan. We face it in our program, and of course the limited procurement. What we found as a solution is expand the evaluation process. So we're evaluating all relatives of kids before we suspect that this patient will be in need of a liver transplant. So once we receive the case and we are prognosing that this case will in the future, especially the biliary atresia, will be in need of liver transplant. So we're starting to evaluate all family members. Challenge number 2 is ICU, of course, the critical care. It's not about just do the surgery in an infant, especially. It's about how to take care of them, how to manage them post-operatively, how to prepare them for surgery as well. In ICU, especially, we trained our ICU doctors in foreign high-flow centers. Complications management, complications, of course, thrombosis, rejections, infections, what we face it. Very few cases we do not face any complications, but mostly at least one complication. It can be the thrombosis, rejection, or infection we are facing now. It's too early to speak now, it's 2 years, but in 5-10 years, we can present our long-term results. And of course, PICU, our center is a pediatric surgical center. It's not a liver transplant center, so ICU beds are limited for us. So far, we have only 2 beds for whole program. What is the solution we see now? expand the PICU, especially dedicated liver transplant ICU doctors, and continue training, especially doctors, nurses, intensivists in foreign centers. So here you see our doctors. We are taking care, as a pediatric transplant doctors, surgeon doctors, we're taking care of all our patients in one team with ICU doctors. Challenge number 4, probably the main problem, it was resource constraints. Medications, cost availability of pediatric immunosuppression formulas, it was limited on a initial stage of programs, but nowadays all these problems are solved, fortunately. And surgical consumables, many microsurgical instruments, branded disposables, and suture materials is very hard to maintain to your hospital on a continuous maintenance. So what we found solution, we applied for the governmental funding increase. Government increased it. We are more than happy. And international partnership regarding the disposable, which is not registered hospital. If hospital cannot buy them, so we can deliver to a hospital through the many international grants and funds, and procurement of instrument, of course. So what solutions in general implemented? As I said, international training is a cornerstone in a program. We cannot start just an rough experience we have. We implemented experience of very high flow and high reputation hospitals. Protocols, everything protocolized in our treatments. Dedicated ICU, dedicated operation room team, dedicated nurses ward especially. And of course, the quality improvement and regional collaboration, which I see the main cornerstone. So here you see our last collaboration agreement with the Renchi Hospital, highly recommend. And this is the academician Janji, the one of the founders of pediatric surgery, and his motto, inherit and innovate, preserve and advance, which we found very useful, and we are trying to follow this route. Future directions, what we see and we are planning our strategies is achieve the 1 case in a week of infant transplantation, which I see, I believe is truly demand nowadays in Uzbekistan. So 1 case in a week, we can cover whole demand of liver transplant in infants in Uzbekistan. Expand, of course, PICU beds, because you never know what may happen. Complications always can happen, so ICU stage can be delayed. And mid-term, of course, midterm DDLT, developed the DDLT program. We don't know so far how to manage it, but we have to manage a DDLT program as well. And to become, 5 years maybe, to become the regional referral center, so we can assist and share our experience with other hospitals in whole region, not only in our country. And of course, the research and education. We are nowadays on a way to establish the first fellowship program of pediatric liver transplant program. And we are publishing, so far we are publishing a lot, but I really do believe that it's not enough, the publications we are publishing and research which we are conducting. So we have to improve it, of course. This is a takeaway messages from our route we face it. So feasible that if you are still in a research limit, it's feasible to establish even a liver transplant program in even in Uzbekistan. It's not about high costly fancy instrument disposables. It's about how to use it, how you see the way to help the babies. International collaboration still, of course, on a very high maintenance, and scaling 1 year in 1 year probably. We already started. We already reached this numbers, but are not established it yet. 1 case in a week of infant transplantation. And of course, systematic approach to everything. Every problem can be approached systematically. If we analyze it, you can solve it. I believe in this. And thank you very much. this is one of our last cases of liver transplant. I'm more than happy to answer the questions.
Thank you, Dr. Nasirov. Questions will be taken at the end of the session. Now, let's move on. Okay. Now, I wish to invite Dr. Let's invite.
Okay, okay. Next presentation regarding the graph volume increase in the early margin deposition and the hemodynamic change after leaving donor liver transplantation, Dr. Babajanov.
Ассаламу алейкум. Ну, прежде всего, от имени администрации, от имени нас, участников этого конгресса из Национального медицинского центра, разрешите поблагодарить организаторов за возможность, предоставленную возможность участия в данной конференции. Лично Октябрю Рукулаевичу большое спасибо за то, что гепатобилиарная хирургия такого объема, именно научное обсуждение, они дошли наконец до Республики Узбекистан. И от всей души поздравляю нашу гепатопанкреатобилиарную хирургию, нашу ассоциацию трансплантологическую с таким знаменательным событием. Сегодня наша презентация посвящена одной из важнейших тем в трансплантологии в целом, дисфункции графта и, в частности, такой проблеме, как изменение параметров объема трансплантата в ранние сроки после родственной трансплантации печени за счет гемодинамических аспектов. Но не секрет, что сейчас на первое место среди таких сложно коррегируемых осложнений выходят различные варианты дисфункции графта. В современной литературе у нас есть разграничения, то есть это варианты ранней дисфункции графта, это первичный нефункционирующий трансплантат, и small forsyth синдром, то есть это синдром малой доли печени, то, о чем уже вопросы возникали, с низким GRVR для реципиента. Если синдром ранней дисфункции, в принципе, относится к коррегируемым осложнениям, то ПАТ, то есть ранее первично нефункционирующий трансплантат, это не коррегируемое осложнение, которое развивается в течение первой недели, и пациент, как правило, без ретрансплантации погибает. Для small forsyth синдрома существует очень много различных критериев, было около десятка описаний этих критериев, как и когда диагностировать small forsyth синдром. Но в целом они все сводились к тому, что это малый объем печени, то есть недостаточный для потребностей реципиента. То есть выставлена была граница в 0,8%, и все, что меньше, считалось как small forsyth синдром. Однако многие исследования за последние где-то 15 лет показали, что даже при объеме трансплантата более единицы развивается аналогичная картине для small forsyth синдрома дисфункция трансплантата. То есть в данном случае уже была обоснована роль как раз других факторов, не только самого объема печени. Это привело к тому, что приблизительно чуть больше 10 лет назад произошла смена парадигмы от small forsyth синдрома к small for flow синдрому. То есть это от малого объема к малому объему для потока. Для чего была высказана первичная теория, что очень большую роль в этом играет именно высокое остаточное портальное давление, то есть портальная гиперперфузия трансплантата, гемодинамическая перегрузка трансплантата, которая ведет к отеку, целому каскаду цепных реакций и приводит к тяжелой иногда дисфункции трансплантата и довольно длительному такому периоду реабилитации. И вот на слайде указаны критерии для small forsyth и для small for flow синдрома. Видно, что то, о чем я говорил, что повреждение в случае small for flow синдрома идет за счет именно портальной гиперперфузии. Значит, после этого на согласительной конференции Международного общества трансплантации печени уже была принята новая формулировка для этого синдрома. То есть это сейчас клинический синдром, возникающий после трансплантации фрагмента печени. который недостаточен для удовлетворения потребностей реципиента при отсутствии специфических хирургических и нехирургических проблем. Были даны градации для этого синдрома, то есть А, Б, С, категории, свои показатели билирубинемии для этого всего. И в этом плане, значит, малый для потока, как оказалось, это одно из довольно частых проявлений в родственной трансплантации печени, когда мы имеем, в принципе, большой стандартный графт, но после операции имеем некоторую дисфункцию трансплантата, которая протекает также по типу, как и другие дисфункции, с теми же клиническими признаками. То есть, по факту, она соответствует пострезекционной так называемой болезни, когда выполняешь большую резекцию печени. То есть мы имеем печеночную недостаточность на фоне просто недостаточного объема печени. Так вот, каскад реакций приводит к тому, что портальная гиперперфузия вызывает повреждение синусоидов. Синусоиды автоматически вымывается такой фермент, как аденозин. Исчезновение аденозина приводит к активации буферного ответа печеночной артерии, который просто в результате которого печеночный кровоток снижается. И это как бы вот такая цепная реакция, которая приводит к увеличению портального давления, снижению артериального кровотока и повышению риска различных ишемических и перфузионных осложнений. Именно вот с буферным ответом печеночной артерии связывают очень много теорий для дисфункции трансплантата. Были показаны в различных исследованиях даже какие-то минимальные критерии, какой должен быть кровоток печеночной артерии, какой должен быть объем кровотока по печеночной артерии в пересаженном графте. Но в целом это абсолютно реальная теория, когда за счет портальной гиперперфузии мы получаем снижение артериального притока к печени, так как имеется уже сама по себе гемодинамическая перегрузка графта, которая приводит, к сожалению, в дальнейшем уже к различным перфузионным осложнениям и ишемическим проявлениям. Для того, чтобы корректировать эти проблемы, скажем так, не корректировать, а для целей профилактических мер, если small for size синдром, мы можем заведомо знать, что мы идем, допустим, на низкий графт 0,6-0,7%, то для small for flow синдрома мы можем, это как бы управляемая сторона трансплантологии, мы можем различными путями модуляции скорректировать портальный кровоток, то есть снизить объем притока, именно портального притока крови в сторону графта. Какие существуют варианты этой коррекции? Ну, прежде всего, самые простые – это фармакологическая коррекция, это радиологическая, в частности, эмболизация селезеночной артерии, это хирургическая, самая частая манипуляция, перевязка селезеночной артерии, также рекомендуется спленэктомия и различные варианты временных портосистемных шунтирований, так называемые гемопортальные портоковальные шунты, которые также позволяют снизить приток крови именно к графту. И одна из последних операций – это деваскуляризация селезенки, предложенная в 2019 году. Из этих всех манипуляций перевязка селезеночной артерии относится, наверное, к самой такой простой манипуляции. Всегда можно интраоперационно найти, выделить фрагмент селезеночной артерии и перевязать его. Спленэктомия гораздо более грубое, технически грубое хирургическое вмешательство. За ним стоит целый спектр осложнений, который характерен для именно постспленэктомического синдрома. Деваскуляризация селезенки, как я уже сказал, в 2019 году была предложена. Технически также она выполнима, но пока результаты этой работы требуют дальнейших изучений. Это как бы на этапе развития. Национальный медицинский центр за 25 и вот полгода 26 года в нашем центре выполнено 210 трансплантаций печени от живого донора. 2 команды работают в этом направлении, 2 отделения трансплантологии в нашем центре. Значит, для того, чтобы оценить изменение объема графта в ранний период, нами была отобрана небольшая группа в 46 пациентов, 22 реципиента, значит, были отнесены в группу модуляции, им была выполнена перевязка селезеночной артерии, 24 реципиента без модуляции. Ну, возраст средний около 40 лет, возраст донора около 35 лет. Значит, в среднем показатели МЭЛТ на момент операции были около 17 баллов. Изучение проходило по данным мультиспиральной компьютерной томографии донора-реципиента до операции и у реципиента на 5-7 сутки после ортотопической трансплантации правой доли печени. Значит, по полу, значит, приблизительно одинаково, женщины и мужчины. Гепатит Б-дельта фактически в 90% случаев. Был вопрос по поводу, почему такая высокая. Ну, мы переживаем сейчас ту ситуацию, когда в Узбекистане вакцинация, она началась только фактически против гепатита Б с начала 2000-х годов. И поэтому сейчас к нам поступают пациенты, которые вовремя не вакцинировались, к сожалению. И вот Б-дельта пока остается наиболее частой проблемой. Но хочу отметить, что за последние 15 лет средний возраст циррозов у нас сместился. Раньше это было 25 лет. Мы работали в хирургии портальной гипертензии, оперировали пациентов, средний возраст которых был 25 лет. Это люди с декомпенсированным по гемодинамическим аспектам циррозом печени. Сейчас средний возраст именно на трансплантацию печени, которые идут пациенты, около 40 лет. Значит, ну, исходные показатели объемные у доноров и реципиентов. В среднем у доноров правая доля 800, около 800 грамм. В среднем наш объем пересаженной доли соответствует где-то около 1,3-1,2%. Это абсолютно нормальные показатели с колебанием от 0,6 до 1,7. Ремнант у донора оставался в пределах 37-38%. Берем мы доноров, оперируем всегда при отсутствии гепатоза первой степени с остаточным графтом не менее 30%. Вес графта на этапе бэктейбл около 660 грамм. Ну и разница между МСКТ данными, то есть в объеме в миллилитрах, и весом графта на этапе бэктейбл приблизительно 20%. По литературным данным скажу, что это где-то около 10%, но у нас пока получается около 20%. Итак, значит, на 5-7 сутки после трансплантации печени объем прироста графта в группе модуляции составил в среднем 35%, тогда как в группе без модуляции уже на 5-7 сутки фактически на 55% увеличился средний прирост. То есть если в абсолютных показателях 283 в группе модуляции, без модуляции более 400 миллилитров. Мы исследовали эти группы в плане того, какой объем можно считать, в принципе, физиологичным в эти сроки. И получилось, что сейчас на данный момент это до 35%. Тогда, то есть объем графта увеличение объема графта до 35% не дает уже нам... Все, заканчиваю я. Буквально 2 слайда, значит. Коротко скажу, что перевязка селезеночной артерии, она позволяет не только снизить гиперперфузию, она позволяет убрать, нивелировать синдром тот самый Хаббар, печеночной артерии, в которой нам за счет перевязки мы, наоборот, усиливаем приток, показанный на дальнем слайде. И в целом это отличается действительно хорошая манипуляция хирургическая. Мы ее проводим не только по определенным показаниям, которые там селезеночная артерия там, шире 5 мм, но и в случаях, когда имеем достаточно высокое портальное давление выше 15 мм ртутного столба. Спасибо за внимание.
Спасибо вам. No, further questions for the speaker? Questions?
Thank you very well. That concludes this session. Thank you for your all participation and colleague. Now we can move on to next session.
Good morning. This is okay. Yes, it's my canal.
Good morning, dear colleagues. I would like to welcome you to this session of the second day of Congress. We have missed the time. Our session topic is acute and chronic pancreatitis, multidisciplinary challenges and evolving treatment paradigm. Each presentation will be 15 minutes long and questions will be taken after all presentations have been completed. Our first speaker is Selman Alkan from Turkey. His presentation is entitled Supportive Care in Acute Pancreatitis, Fluids, Nutrition and Monitoring.
Good morning, dear chairs and distinguished participants. It's a great pleasure to be with you at this scientific meeting. I'd like to thank our Congress President, Professor Mustafa Kerem, and the scientific committee. And I wish our Congress a productive and successful meeting. Acute pancreatitis is one of the leading gastrointestinal causes of the hospital admission worldwide, and its incidence continues to rise. The increase is mainly driven by obesity, gallstone disease, and metabolic syndrome. Although most cases are mild, nearly 20% of patients develop severe acute pancreatitis. The key point is that mortality is mainly determined not by pancreatic necrosis, but by persistent organ failure. Therefore, supportive care is not an adjunct, it's a central component of acute pancreatitis management. In the early phase of acute pancreatitis, we are not dealing only with a local inflammatory process. We are managing a systemic microcirculatory storm in which persistent organ failure may increase mortality up to nearly 40%. Since we still do not have a magic bullet, pharmacological agent to stop this progression, supportive care remains our most powerful therapeutic tool. Survival depends on how early we can break the vicious cycle of capillary leakage and acinar ischemia through carefully guided moderate fluid restoration and early reactivation of the bowels. Several scoring and classification systems have been proposed for acute pancreatitis, including BICEP, Apache, Ranson, and SIRS. However, recent meta-analysis shows that these traditional scores have limited bedside value in predicting the clinical course. Although they are useful for ruling out severe disease, their ability to predict severe pancreatitis is modest, especially in terms of positive predictive value. Therefore, our current approach has shifted from relying on single score to performing serial clinical assessment. Persistent SIRS lasting more than 40 hours remains one of the most important bedside warning signs. In the past, we often tried to assess the severity of acute pancreatitis mainly based on CT findings. Today, however, we know that the key determinant of the mortality is not the pancreatic image, but persisting organ failure is very important. This is why the revised Atalanta classification categorizes patients as mild, moderately severe, and severe acute pancreatitis. The critical threshold is 48 hours. If organ failure persists beyond 48 hours, the patient should be considered to have severe acute pancreatitis. Respiratory, renal, and cardiovascular failure are particularly associated with mortality. We often focus on necrosis, but necrosis is really what kills the patients. Not primarily, it's persistent organ failure. Early fluid resuscitation is one of the key components of supportive care in acute pancreatitis. The main goal is to preserve pancreatic microcirculation, prevent tissue hypoperfusion, and reduce the risk of necrosis. However, our approach has changed significantly in recent years. Aggressive hydration was previously recommended, but the waterfall trial showed that this strategy does not benefit all patients and may increase the risk of fluid overload. Therefore, the current principle is no longer the more fluid, the better. Today, Today we have changed the strategy, and goal-directed strategy is very helpful. For many years, early and aggressive fluid therapy was believed to prevent necrosis in the acute pancreatitis. Therefore, high-volume fluid boluses were routinely used in many centers. However, the waterfall trial published in 2022 seriously changed the approach. The study compared aggressive fluid resuscitation with moderate resuscitation. The results were striking. Aggressive fluid therapy did not reduce the development of severe pancreatitis. There was also no significant difference in organ failure or pancreatitis-related complications. However, aggressive hydration increased the risk of fluid overload by nearly 3 times. And the trial was stopped early for the reason. After this study, the paradigm of fluid therapy in acute pancreatitis has changed significantly. In the past years, not much attention was paid to which crystallate was used in acute pancreatitis. However, in recent years, the lactated ringer particularly has been shown to have some significant advantages over regular saline. Normal saline can cause hypochloremic metabolic acidosis due to its high chlorine content. This can negatively affect pancreatic microcirculation and inflammation. Lactated ringer, on the other hand, has a more physiological composition. Meta-analysis shows that lower source rate, less ICU need, and lower local complication rates. For this reason, the preferred fluid in current guideline is now recommended as lactated ringer. So, if we have abundant aggressive approach, how much fluid exactly should we give the patient today? After our waterfall trial, our approach has completely changed. We no longer administer automatically bolus to everyone. The current approach is intermediate fluid resuscitation. Initially, lactated ringer is preferred, and it administered at the rate of approximately 1.5 milliliter per kilogram per hour. Bolus, on the other hand, should only be considered in case of hypotension, tachycardia, mild hypovolemia, or severe hypertension. The goal here is not to give a specific liter target. Purpose to protect pancreatic perfusion, prevent BUN rising, and avoid fluid overload. For this reason, fluid therapy is seen as a dynamic process, not a prescription today. The fixed volume approach has been abundant, goal-directed resuscitation has become the key concept, and dynamic reassessment is essential. Hypovolemia status should be evaluated in the patient's clinic. Bolus loading should be preferred if present, and the targeted fluid therapy should be applied in the form of infusion. After the 6 or 12 hours later, first fluid replacement, BUN, and the hematocrit must be re-evaluated. Hourly routine output and vital signs should be re-evaluated. Today, fluid therapy is not just about determining the infusion rate. The most important thing is to evaluate how the fluid we give creates a response in the patient. Therefore, serial monitoring is critical. BUN level decreases or remains stable, it's one of the most important of adequate resuscitation. Similarly, the continued rise of hematocrit may suggest ongoing hemoconcentration, urine output mean, arterial output, and clinical examination must also included in the evaluation. In addition, lung yield sonography and inferior vena cava evaluation, it's very useful detecting the fluid overload at an early stage. Because as much as insufficient liquid, excess fluid can also harm the patient. For many years, patients with acute pancreatitis were kept fasting. The rationale seemed logical. If we do not stimulate the pancreas, it will rest and recover. We believed in past that. However, later studies showed that this concept was not entirely correct. Fasting does not simply protect the patients. It may also impair the intestinal barrier. Prolonged fasting can lead to mucosal atrophy, increased intestinal permeability, and bacterial translocation. Therefore, the current approach has changed completely. Our goal is no longer to rest the pancreas, but to preserve the gut barrier and reactivate the intestine as early as possible. One of the most important changes in nutrition is mild acute pancreatitis. In mild acute pancreatitis, patients should no longer be fasted for a long time. Up-to-date guidelines is that it recommends that feeding be started within the first 24 hours in patients who tolerate oral intake. Moreover, it has been shown that the approach of starting from clear liquid and progressing gradually, which we routinely applied in the past, it's not mandatory. It has been found safe to start with a low-fat solid diet. Early nutrition reduces the length of stay, increases patient comfort, and accelerates the healing. Therefore, hunger is no longer a treatment method. It is seen as a situation that should be avoided as much as possible. In severe acute pancreatitis, oral feeding may not always be possible. For many years, total parenteral nutrition was commonly used, sometimes probiotics. However, current evidence clearly shows that enteral nutrition is associated with lower infection rates, lower mortality, and less organ failure. The main benefit comes from preserving gut barrier. Enteral feeding maintains the intestinal mucosa, reduces the bacterial translocation, and helps to prevent infected pancreatic necrosis. Therefore, if oral intake is not possible, enteral nutrition should be started as early as possible. In a study from China, in the length of hospital stay analysis, early findings scientific reduced the stay compared with the late feeding. Patients receiving early nutrition were discharged on average 2.35 early. No significant differences were observed between early and late feeding in terms of feeding intolerance, nausea, or vomiting, and mortality rates were also similar. Therefore, early nutrition shortens hospitalization without increasing the adverse effect of mortality risk. In mild pancreatitis, oral feeding showed a statistically significant advantage compared with tube feeding. In several cases, comparison of nutritional content demonstrated that a low-fat diet was significantly superior to clear liquids as special nutritional formulas. In mild acute pancreatitis, feeding within the first 24 hours was significantly advantageous compared with late feeding. Immediate hospitalization was also significant. In severe acute pancreatitis, unlike mild acute pancreatitis, initially feeding after the first 24 hours appeared to be safer and more beneficial strategy and delayed feeding. In acute pancreatitis, the most important factor determining the need for close monitoring and intensive care is need. In particular, patients with a modified Marshall score of 2 or higher should be carefully evaluated. Patients who develop respiratory failure, hemodynamic instability, or acute kidney injury should be considered for intensive care. The important point here is that high CRP level or extensive pancreatic necrosis alone is not an indication for ICU admission. The decision should be based on the patient's physiological status. In addition, elderly patients, obese patients, and those with significant comorbidities should be evaluated for intensive care with a lower threshold. One of the commonly overlooked problems in severe acute pancreatitis is intra-abdominal hypertension. Capillary leakage, retroperitoneal edema, ileus, and excessive fluid administration can all increase intra-abdominal pressure. When the pressure exceeds 12 millimeters of mercury is defined as intra-abdominal hypertension. When it exceeds 20 millimeters of mercury and it's associated with organ failure, it's called abdominal compartment syndrome. This condition may reduce renal perfusion, impair ventilation, and accelerate the multiple organ failure. Therefore, especially in patients with severe acute pancreatitis, bladder pressure measurement is an important monitoring tool in ICU units. The main goals of treatment are to reduce positive fluid balance and preserve organ perfusion. Surgical decompression should be considered only as a last resort. To summarize the entire talk, supportive care in acute pancreatitis is built on 4 main pillars. The first is appropriate fluid therapy, moderate cold-diuretic resuscitation with the lactated ringer solution. The second is early nutrition, oral or enteral feeding as early as possible. The third is close monitoring, early recognition of organ failure, and adjustment of treatment accordingly. And finally, there are practice we should know leave behind aggressive fluid loading, unnecessary fasting, prophylactic antibiotics, and routine probiotic using is not necessary. In fact, the management of pancreatitis is becoming less invasive, more physiological, and more evidence-based. In conclusion, supportive care no longer just an adjunctive approach. It is now at the center of the treatment. Supportive care is no longer merely supportive. Maybe it's the treatment itself. Thank you for your attention.
Thank you, Professor Algan, for your talk. We'll get to questions at the end of all the presentations altogether in the discussion part. Now, I would like to invite our next speaker, Professor Kemal Dolay. He will be presenting us necrotizing pancreatitis, current perspectives on timing and techniques of intervention.
Dear colleagues, I would like to thank the organizing committee. In this presentation, I will discuss necrotizing pancreatitis, a condition where management has changed dramatically over the past four decades, driven by landmark trials. As we know, approximately 20% of patients with acute pancreatitis develop pancreatic and peripancreatic necrosis. The disease has a biphasic course. In the first 2 weeks, the dominant threat is cytokine storm and systematic inflammatory response. After 2 weeks, the late phase begins and characterized by local complications and infected necrosis. The revised Atlanta classification introduced two important entities. Acute necrotic collection and walled-off necrosis. Acute necrotic collection occurs in the first 4 weeks. These collections lack a mature wall and contain both fluid and solid debris. In contrast, walled-off necrosis develops after approximately 4 weeks and is surrounded by a well-defined inflammatory capsule. As I mentioned earlier, the management of acute necrotizing pancreatitis has undergone several major paradigms over the past 4 decades. I will share the remarkable evaluation of the treatment strategies that I have personally witnessed from my early years as a medical student to the present day. In 1985, Hans Beger published his landmark results advocating early open surgical intervention for all patients with pancreatic necrosis identified on CT, regardless of whether the necrosis was infected or sterile. His technique, open necrosectomy followed by closed continuous lavage with 8 liters of saline per day, achieved a mortality rate only 8.5%, an impressive result for that era. This approach became the standard of the care and dominated the clinical practice for nearly a decade. At my medical faculty, we also adopted this strategy. However, in our own experience, mortality rates remained high. Bradley and Allen in 1991, who demonstrated that patients with sterile necrosis could recover without surgery, even in the presence of organ failure. This concept was rapidly embraced, and by the early 2000s, several large studies had confirmed that non-operative management of sterile AMP was associated with lower morbidity and mortality than surgical intervention. A new paradigm emerged: observe sterile necrosis, operate on infected necrosis. In 2005, Ranzi and colleagues demonstrated that even in the presence of infection, 60% of patients with acute necrotizing pancreatitis could be successfully treated without surgery using antibiotic and intensive supportive care alone. Moreover, the reported mortality rate was only 12.5% compared with the 20 to 50% mortality rates commonly reported in contemporary surgical series. These findings challenge the prevailing paradigm that infected necrosis equals surgery. In 2010, colleagues further validation this approach. A new paradigm emerged. Do not operate immediately on infected necrosis. Start with antibiotics and reserve surgery for the patients who fails conservative treatment. Timing is one of the most critical variable in AMP surgery. Myers' prospective study showed early necrosectomy carries 58% mortality versus 27% for delayed surgery. Besseling's data were even more striking. Mortality 75% for surgery in the first 14 days, falling to 8% when delayed beyond 30 days. Hartwig confirms similar findings with laparotomy. The practical message is clear. Avoid surgery in the first 2 weeks whenever possible. When clinically feasible, delay all interventions beyond 30 days to allow necrosis to wall off. Once the indication of intervention in infected AMP has been established, the next challenge is choosing the optimal techniques of intervention for the individual patient. The Panther trial is landmark. It was the first randomized control trial to compare primary open necrosectomy versus a step-up approach, percutaneous drainage first with surgical necrosectomy only. If drainage failed, surgery was avoided altogether in 35 patients of step-up group. Major complications, new onset diabetes and organ failure were significantly less frequent in the step-up group. However, mortality rates were similar between the two groups. The Panther trial essentially ended the era of primary open necrosectomy as a default approach for infected acute necrosis and pancreatitis. Another important study was published by Neoptolemus and colleagues in 1910. In this study, the authors showed that minimal invasive retroperitoneal necrosectomy was superior to open surgery. Overall complications 55 versus 83%. Mortality 19% versus 38%. These results solidified minimally invasive approach as the preferred surgical route when surgery is needed. The next major step came in 2012 with the Penguin trial published by Dutch Pancreatitis Study Group. Despite its small sample size, it was the first RCT trial to directly compare endoscopic and surgical necrosectomy. The findings strongly favored the endoscopic approach. No new organ failure in the endoscopy group versus 50% in surgical group. Major complications reduced from 80% to 20% and mortality from 40% to 10%. This impressive result paved the way for the widespread adaptation of endoscopic step-up strategies. Another landmark study was the tension trial published by the Dutch group comparing endoscopic versus surgical step-up. Endoscopic step-up did not prove superior regarding major complications and mortality, but it was associated with significantly shorter hospitalization and a much lower pancreatic fistula rate. The trial tells us that both approaches are valid, but endoscopic step-up should be preferred when technically feasible. The Miser trial from Florida compared endoscopic step up using lumen approximating metal stents versus laparoscopic cystogastrostomy and video-assisted retroperitoneal debridement. Endoscopic step-up approach is superior to minimal invasive surgery in terms of major complications, length of hospital stay, healthcare cost, and quality of life. However, mortality rates are similar between the two approaches. This trial reinforces endoscopy as the preferred first-line approach with suitable anatomy. The Pointer trial, again from Dutch group, addressed a practical question. Should we drain infected acute necrotizing pancreatitis immediately or antibiotic first and wait? Immediate drainage led to significantly more interventions. Strikingly, 39% of patients in the postponed group never needed any drainage at all and were successfully treated with antibiotics alone. Mortality was similar. The clinical message is clear. Avoid routine early drainage, start with antibiotics, monitor the patient closely, and proceed with drainage only if there is no clinical improvement or clinical worsening. A 2021 meta-analysis by Ritchie et al. Published Annals of Surgery identified endoscopic step-up therapy as the most effective treatment strategy of infected acute necrotizing pancreatitis. This slide summarizes our current management strategy for acute necrotizing pancreatitis. The management of these patients should ideally be undertaken in multidisciplinary collaboration. In general, the management can be summarized by the principle of 3Ds: delay, drainage, and debridement. Once the diagnosis has been established, the cornerstone of treatment during the first 2 weeks is intensive supportive care. During these periods, patients should be kept away from surgery and necrosectomy whenever possible. The next critical question is: necrosis is infected. If infection is suspected or confirmed, antibiotic therapy should be initiated and every effort should be made to delay intervention until the necrotic collection becomes encapsulated as walled off necrosis. If sepsis persists despite antibiotic treatment during the early phase, percutaneous catheter drainage may be required for source control. After approximately 4 weeks, if intervention is still necessary, the preferred strategy is endoscopic step-up approach. If endoscopic treatment is unsuccessful or technically not feasible, a stepwise escalation strategies should be followed. This may include percutaneous catheter drainage, followed by minimal invasive surgical techniques like video-assisted or minimal invasive retroperitoneal necrosectomy when required. In more advanced cases, laparoscopic necrosectomy may be considered, while open necrosectomy should be reserved as a final option for careful selected patients. If the necrosis is sterile, patients should be managed conservatively with close observation. In asymptomatic patients, no intervention is indicated regardless of the size of necrotic collection. However, in symptomatic patients presenting with pain, intestinal or biliary obstruction, or the persistent unwellness, intervention may be necessary. In these cases, the collection should be allowed to mature for at least 6 to 8 weeks whenever possible, followed by endoscopic drainage as the preferred treatment. Finally, patients who develop major complications of acute necrotizing pancreatitis, such as gastrointestinal perforation or major vascular hemorrhage, they may require emergency laparotomy and definitive surgical therapy. Before I finish, I'd like to present a representative case of biliary infected acute necrotizing pancreatitis, demonstrating how we applied the step-up approach in daily clinical practice. A 69-year-old man presented with acute biliary pancreatitis. Initial laboratory and imaging studies confirmed the diagnosis. By day 3, CT showed extensive necrosis involving the pancreatic body, and MRCP demonstrated dilated common bile duct and small stone in the distal common bile duct. Due to persistent jaundice, ERCP with sphincterotomy and biliary sludge extraction was performed, leading to rapid resolution of biliary obstruction. During the second week, the patient developed fever and elevated inflammatory markers, and repeat CT confirmed infected pancreatic necrosis. You see the big acute necrotic collection and the gaze in the collection. This is infected acute necrotic collection. In this patient, intravenous antibiotics were started with the while invasive intervention was delayed for step-up approach. Despite antibiotic therapy, the patient developed recurrent signs of infection during the third week, and the step-up approach was initiated, and percutaneous catheter drainage was selected as the first-line intervention. Although the patient initially improved, the infection recurred in the fourth week. The second step-up treatment was performed with endoscopic ultrasound-guided cystogastrostomy using a self-expandable metal stent, followed by endoscopic necrosectomy session over the subsequent days until complete debridement was achieved. This SEMS was removed first, followed by removal of percutaneous drainage catheter after complete resolution of the collection. The patient recovered without requiring surgical management. In this video, you see the endoscopic and fluoroscopic guided cystogastrostomy access to necrotic collection, world of necrosis, and then we insert the self-expandable metal stent, and then change the endoscope, routine gastroscope, therapeutic gastroscope, extraction of necrotic debris, additional to intervention. We performed this patient. In the last intervention, we grasped the big piece of pancreatic necrosis and then take it out. You see the grasping the big, huge pancreatic necrosis and then take it out. You see the pancreatic necrotic tissue unblock excision with the endoscopy. Rahmat, teşekkürler. Thank you.
Are you there any questions and comments, please? Then, yes, okay. Thank you, Professor. Good morning. I am pleased to present our Professor Kaya Saribeoglu, to presentation surgical management of chronic pancreatitis.
Dear Chairman, dear colleagues, thank you very much. Thank you for the invitation. Also, I will talk about the surgical management of chronic pancreatitis. My talk will be in 3 different sessions. First, I will talk about the indications very shortly. Then techniques of the chronic pancreatitis surgery, some details I will present. And last point, we will talk about the outcomes of these operations. As you all know, chronic pancreatitis is the chronic inflammation of the pancreas with an irreversible damage of the pancreas. That's why it's not always a surgical patient. It's nowadays rarely the patients are going to surgery. And what about the etiology of chronic pancreatitis? As you can see, this is the last Tiger O classification. As you can see, there are diverse etiology of chronic pancreatitis. Worldwide, the most common cause is alcohol consumption, but there are also some genetic susceptibility to the disease or genetic etiology, especially as you see this in this blue one, PRSS1 mutation. It's related with hereditary chronic pancreatitis. It's important. These patients has significantly increased risk of pancreatic cancer. Some autoimmune diseases or due to obstruction, you can see in the long term chronic pancreatitis. Why did I bring this? I did bring this slide because different indications, different etiologies, and they need different treatment strategies. As for the indications, we operate the patients mostly because of the pain, but also there are some cases where we operate the patient because of pseudocysts or bile duct strictures, sometimes because of tumor suspicion, cancer risk, or duodenal obstruction or splenic vein thrombosis. Most of the patients, they are treated with conservative measures. Now, not to forget that. It's nowadays rarely indicated to surgery, but if it's indicated, it shouldn't be delayed, of course. It's an example of a pancreatic chronic pancreatitis with an inflammatory mass in the head of the organ. And as you can see, there's a bile duct stricture, and this somewhat some kind of duodenal obstruction also. This patient needs sooner or later a surgery. That's why we have to make a very good selection of the patients. Apart from the pain and or tumor suspicion, we can treat the patients with also endoscopic or interventional measures. For example, for pseudocysts, we can perform an endoscopic cystogastrostomy. It might be also a resection, surgical resection, or surgical decompression. For the bile duct strictures, we have an option of endoscopic stent insertion. We can do also a bypass surgery. Duodenal obstruction, you can perform an stent insertion as well as a surgical bypass. And for the splenic vein thrombosis, because of the gastric varices, you can perform a splenectomy. It's an example of, once again, a severe chronic pancreatitis with complete atrophy of the organ. And also in the head, you can see a large pseudocyst. This patient had a diabetes, type 2 diabetes, insulin dependent, and it is a candidate for a total pancreatectomy. And but you can also manage the head pseudocysts through an endoscopic option. That's why you can select the patients really individually by all cases. There is not a clear-cut answer for all. If the surgeons see a tumor suspicion on the imaging findings, we should think about the oncological surgery. the tumor suspicion should be, we should be very cautious about the indication, and it should be treated like in pancreatic cancer. That's why I will not focus on this site. If you have a tumor, not inflammatory, neoplastic tumor in pancreatic head, it should be treated like an pancreatic adenocarcinoma. As for the techniques, for the chronic pancreatitis in the literature, you will see a lot of different techniques, and the oldest one is Pusto procedure. Dr. Pusto published 1958, the first Pusto procedure. At that time, it was together with a distal pancreatectomy and splenectomy, the original description. It was too much. That's why Partington-Rochelle procedure was suggested. They have reduced this technique. They perform just a longitudinal pancreaticojejunostomy. The aim in this procedure is to decompress the pancreatic duct. There isn't any resection, but on the long term, it was seen that this is not enough in most cases because of the inflammation on the pancreatic head. This is the trigger of the pain. And most of these procedures, drainage procedures, are being performed because of severe pain of the patients, which are not manageable with conservative measures. I mean, analgesia or some intervention measures. That's why we are performing these procedures. And that was not enough. That's why it's the example of Partington-Rochelle operation. This is just a side-to-side longitudinal pancreaticojejunostomy. It is rarely performed nowadays, but in selected patients, it might be useful. It shouldn't be forgot. If the patient doesn't have any inflammatory mass in pancreas, you can consider it. Well, there is another group of procedures, these resection procedures. The conventional resections, it is still the most common operations performed worldwide, also because of chronic pancreatitis. A Whipple pancreatic head resection, distal or total pancreatectomy with or without islet transplantation, island cell transplantation. It's feasible, and dual procedure is the oldest procedure in the chronic pancreatitis, and they perform pancreatic tail resection with an anastomosis. You can just do that. We are all doing that, performing that. Sometimes because of tumor suspicion, sometimes the inflammatory mass is only on pancreatic head. It's convenient to perform it. But duodenum preserving operations were being also suggested afterwards. The first operation suggested was Beger procedure. It was published in 1987, I think. Then it was a very challenging operation because of the tight adhesions nearby pancreatic head. It was not easy to perform it. It was a little bit too risky. That's why some kind of modifications were being suggested, like burn modification. We will see the details afterwards. Prey procedure and Izbitski procedure from Hamburg. There are some other modifications of this operation, but they have all the same concept. The core resection of the pancreatic head, resection of this inflammatory mass from the pancreatic head, together with drainage of the pancreatic duct, with preserving duodenum. This is the Beger operation. It is very rarely performed nowadays, almost never nowadays. But it was the original publication 1980 from by Hans Beger from Ulm University. He was performing a core resection, but a complete core resection of the pancreatic head until portal vein. And he performed 2 anastomoses to the proximal distal side. It's a very challenging operation because of this chronic severe inflammation. That's why the pancreatic surgeons thought about it, and Dr. Frame from USA in 1987 has an idea to perform a core resection, duodenal preserving on pancreatic head, but without reaching portal vein. It's very difficult to mobilize pancreas from the portal vein. As we all know, it's sometimes impossible. And he performed a core resection with preserving duodenum and with also preserving the backside of the pancreas on the neck, and then perform a pancreatojejunostomy laterally. And he also extended the incision to the tail. It's a very easy technique to perform it. It decompresses pancreatic duct, and with this technique you can also very easily remove the stones which are sometimes existing in the pancreatic gland. In 2001, Dr. Biliary, he was working at that time in Switzerland, in Bern. He published his burn modification. It is somewhat different. There are minor details between those techniques. What are the differences with the Fry technique? He is performing a core resection of the head, but he's opening the distal bile duct, and this is the advantage of this technique. With this technique, you can decompress also the bile duct. It's very convenient by the patients, in the patients who have bile duct strictures and cholestasis. But there's a disadvantage of this technique. He's not doing an incision in the direction of the tail. That's why with this technique, you cannot remove the stones from the corpus or tail side of the pancreas. But it's also a very delicate technique. And from Hamburg, Professor Izbitschke, he was working with the team of Brösch, and he just advocated, this is also a minor modification of Fry technique, I think, that he was doing not a core resection of pancreatic.
Dear Professor,
Sorry?
Please, because we are late,
How many
your
minutes?
times, no, yes, your times more 15 minutes.
Okay, I will do it. Are you sure? I'm not sure. Okay, it's the minor technical revision. It's a photo of a Fry operation. As you can see here, we are removing the stones and we are performing the core resection. On the E side, you see just an extremely dilated pancreatic duct, and just we are performing a lateral pancreatojejunostomy. Those are the stones. With Bern modification, it's not easy to remove all these stones from the corpus and tail. This is last slides about the outcomes. When you are comparing the resections, Whipple procedure with this duodenal preserving pancreatic head resection, in all meta-analysis, you see an advantage of duodenal preserving technique in the long term in terms of quality of life. This is one of them. Another meta-analysis from Biliary team, as you can see on the long term, there's an advantage in terms of quality of life or diarrhea. It is a relatively new from Srivardena, assessment for Fry procedure for chronic pancreatitis. I brought this slides. As you see, LSOs NR. Those are not reported. That's why the studies, they are extremely heterogeneous. It's not easy nowadays to have an evidence-based idea about it. And last two slides about the consensus conference of 4 biggest societies on the world. The question is, what's the optimal timing of surgery as soon as possible? If you are delaying the operation, you will see only the complications. Sometimes it's becoming not resectable. And if this second question, what are the surgical options? On the panel, it suggested either burn modification or Fry operation. for chronic pancreatitis. And also on the long term, the pancreatic cancer risk must be reduced if the patient has, as you can see on the bottom side, hereditary pancreatitis because of genetic mutation. Take-home message, I already told that. I'm extremely happy to see that we have right now 15 new students for International HPP Surgery School from Uzbekistan. They have registered yesterday. Thank you very much. And thank you. And you can also take this QR code or from your friends. You can just have the information. And this is totally free. It's a structured HPP Surgery School. Thank you very much. Hangisine bu? Thank you.
Thank you, Professor Sarbayoğlu. This concludes our session. Since we are late, we will not be able to take any questions, and we will continue with coffee break, and you can ask questions during the break. Thank you.
Good morning to everybody. I think that we should start with the third session for today. For me, it's a pleasure to invite on the scene Professor Buscard. He will present us structural learning pathways in minimally invasive pancreatic surgery. Please, the floor is yours.
Good morning, everyone. Dear Chair, thank you for your introduction, and I would also like to thank Congress Organizing Committee for inviting me to give this talk. Today's topic is the structured learning pathways in minimally invasive pancreatic surgery, mastering technique. It does not work. I have no conflict of interest. Yeah, it works. When we look at the robotic pancreatic surgery, what are its advantages? We can tell that due to the ergonomic working environment, reduced surgeon fatigue, and enhanced precision in surgical procedures, it can eliminate human error. And also the three-dimensional imaging with absence of tremor, instruments with high degree of articulation and haptic feedback. It allows us to perform major surgical procedures in complex and hard-to-reach anatomical areas with greater accuracy. And minimally invasive pancreatic surgery, as we all know, during all kind of surgeries, the incisions are also a major concern. In addition to pancreas-specific complications, the wound-related complications are frequently encountered due to the surgery itself, and also factors such as poor nutritional status of the malignant patients. And these general complications include wound infection, wound dehiscence, and hernias. And here you can see some kind of minimally invasive pancreatic surgery incisions. With that trocars, you can easily perform pancreatic surgery or liver surgery instead of those big incisions. And also with these trocars, you can easily perform left-sided pancreatic resections, the assistant trocar on the left side. And with these trocars, you can perform total pancreatectomy even in patients with previous abdominal surgery. And also, this is a new one that you can perform all kinds of these surgeries just with a single incision with minimally invasive techniques. And robots not only shortens length of incisions, it has also caused some improvements on clinical side. Here's an example of a study we published on surgical endoscopy. And at that study, we compared the robot versus open pancreatectomy cases for clinical outcomes and also for cost. And we did a propensity score match between two groups, and we compared them. Yeah, okay. This study showed that robotic surgery results in a significantly lower rate of clinically relevant pancreatic fistula and also a shorter hospital stay. And although it's a reality in current that robotic surgery has doubles the intraoperative costs, but the total cost is similar because of the less complications and also shorter length of hospital stay. And yes, till to here it has some advantages, but the major question is it easy to do actually? And when we look at the learning curve of the robotic has advantages in terms of caseload that needed to be done to reduce operative time and also the complications. And for safety implementing this technique to our clinical practice, we should follow some steps. And during this period, surgeons are recommended to participate in a structured training program and ensure that competency is reached. And here I will give an example of my journey of a structured training program called the LearnBot program, which was developed based on an American model and conducted by Melissa Oak and Mark Besseling. And this program includes the independent simulator training, accessing to an online video data bank, on-site training of robot pancreaticogenestomies and robot hepaticogenestomies performed on biotissues, external site visit, on-site proctoring, and first cases, after all, will be reviewed by an expert. And the program started with the simulator training. They sent us a list of some certain tasks we needed to do for mastering the device. And additionally, we are required to repeat the exercises until achieving an acceptable score with the same level of competence at least twice. And online video discussion is a good way of learning from experts' experience. And those are unedited videos with great details. And also we discuss these videos in person with the experts. And then I go on on-site training. And also the two trainers visited our center for 2 days and practice robotic pancreaticogenestomy and hepaticogenestomy and biotissue models. And these exercises were recorded and the videos were assessed by an expert robotic pancreaticogenestomy surgeon, and we get some influence from experts also. And additionally, I completed an external site visit and finally invited the expert to my hospital for on-site proctoring. And after completed all those steps, I started to do my own cases for robotic pancreatic surgery cases, both robotic pancreaticodenectomy, robotic total pancreatectomy, and robotic left-sided resections. I would also show some tips, not the all surgery, but some tips from the surgeries that I perform. This is a robotic left pancreatectomy case. The staple line is an issue during that operation, and before cutting the pancreas with stapler, I put some bulldog clamps that I implement this technique from Japanese friends. I put 2 laparoscopic bulldog clamp and wait for 7 to 8 minutes. And then I put stapler that thinner line for not to tear pancreas and get a proper staple line. And then I wrap this line with an hemopage and I put some fibrin glue on it. And like yesterday, Professor Radakovic told a trial about not to use drain after left pancreatectomy. I also started not to use drain for left pancreatectomies. I selectively use drain for left-sided resections. And also the trocar sites. This is the case that I performed 4 years ago, a robotic pancreaticodenectomy case. I was using 2 assistant trocar. Now I changed it to the 1 12mm assistant trocar. And also I carry the trocar sites a bit high because with this trocar line, it is hard to reach sometimes to the superior part of the pancreas. And I carry them high and I do dissection more clearly on the superior part of the pancreas also. And I want to show a complication video that I converted this case.
Yesterday, we talked that the complications during the uncinate dissection and also around the superior mesenteric vein usually occurs due to traction and dense adhesions around that location. This is a patient with a pancreatic carcinoma and also the several pancreatitis attacks. And there is a dense adhesions during between those tissues due to the uncontrolled traction. A bleeding starts most probably from the handless arc, and then we put gauze on it and we try to control it, and then we suture it and converted that case open in elective circumstances. Because if you insist on those bleeding and continue surgery on minimal invasive way, in the later steps you can experience an emergent conversion, and it can cause worse outcome also. We know that from the literature that the elective conversions before a major concern occurs during surgery are has same postoperative outcome with the non-converted cases. And this is another example. This is a video of the uncinate dissection that we performed with the monopolar scissors. There's no complication at these videos. Here you can see the superior mesenteric vein. Here is the superior mesenteric artery. And we completed the uncinate dissection with the monopolar scissors. There are some branches coming from the superior mesenteric artery. We clipped it from the assistant side. Also, you can use robotic hemolog clips. This is the last part of the uncinate dissection. Here you can see the gasoduodenal stump, superior mesenteric vein, superior mesenteric artery, and there is also the replaced right hepatic artery at that case. And we continue with the pancreatic anastomosis. We prefer modified Blumgart anastomosis that we implemented our routine from the Netherlands group. We use 2O6 suture. We put 3 U sutures that brings jejunum to the near to the pancreas. We put middle U suture that covers also the pancreatic duct. And after we put a stent to the pancreatic duct, I use silicone ureter stent. It's 6 centimeters in long, 4 in the pancreas and 2 in the jejunum side. And we start to ligate those sutures. It's important not to close pancreatic duct. So we control it with the stent. And we ligate all, and we take stent out to make the posterior wall of the pancreatic geniospasm anastomosis. Also, we leave needle because we will use those sutures for the anterior wall reconstruction. And we do posterior wall of the pancreatic geniospasm with 5O PDS suture. We put 3 stitches and then ligate them. Previously, I was using the feeding tube for the pancreatic duct stenting, but I changed it to ureter stent after speaking with the Professor Kerem. We ligate the posterior wall sutures and then put the stent to the pancreatic duct. You can see it can easily go. There is no obstruction in the duct. And the anterior wall sutures with the same 5O PDS sutures. And at the end, I completed anastomosis with the same silk sutures that I use for the posterior wall. It usually takes 45 minutes to complete pancreatic genostomy robotically. And that's what I want to tell. Okay, thank you.
Professor Buscat, thank you for this nice presentation. Are there some questions from the audience? We have time for one or two short questions. If no, I would like to ask you, what is the percentage of minimally invasive pancreatoduodenectomies in your department, and also the rate of pancreatic fistula after robotic procedures with this modified Blumgart anastomosis? Thank you.
Our previous technique was before the robotic pancreatic duodenectomy period. We were not using the pancreatic duct stenting, and also we were doing the pancreatic genostomy with the separated sutures, not using the silk. After implementing the robotic technique, the pancreatic fistula rate really decreased. It was like 15, and now it's below the 10%. And also for caseload, in the initial phase of this period, it was like 10-1, like 10% minimally invasive cases, but now it exists to the 50% of the cases for minimally invasive.
Thank you. It's nice. One question from Professor Katkov.
Yeah, of course.
Okay, thank you very much. Now it's a pleasure for me to present the next speaker, Professor Katkov from Moscow. As you know, he's one of the most experienced laparoscopic surgeons worldwide in the field of pancreatic surgery. So the floor is yours. Thank you.
Thank you very much for introduction, and the chairman, the colleagues, thank you very much for invitation. It's a great pleasure and honor for me to be here. And we are suggested to make a talk concerning ramps in minimally invasive area. So I would like to start with simply definition. So ramps is radical antegrade modular pancreatic splenectomy. And it was introduced in the surgical practice with the reason that the results of standard distal pancreatectomy didn't satisfy many surgeons, because you see at the end of the previous century, the number of R1 resections was up to 50%, and the local recurrence rate was more than 60%. So that was the reason for many surgeons to make a new approaches, to develop new approaches to surgical technique. And it was suggested by Strasberg with the colleagues. You see in 2003, they described this technique of ramps for the first time. So they said that, postulated that the key to radicality lies at the plane of resection, and suggested four main principles of the proper resection. So it's antegrade left to right mobilization with the early ligation of the vessels, especially artery, in order to prevent spreading of tumor cells and to reduce blood loss. It's also could be two variants of choosing of posterior resection plane. There are anterior ramps when the plane is lying anterior to adrenal gland along the gerota and behind to gerota fascia, and the posterior ramps with the resection of adrenal gland with when we operate tumors T3, T4, or the tumors that involve adrenal gland. And it's also systematic lymphadenectomy in stations 10, 11, and 18. In the future years, until nowadays, we have several publications, a lot of publications, which confirm that the anatomy and surgical technique is reproducible, and this modular approach can be used in many hospitals. And of course, there were a lot of advantages were shown in RAMS resection. So R0 resection rates increased up to 90%, practically up to 90%. The blood loss decreased up to 150 millimeters in average. RAMS showed the possibility for more lymph nodes that could be retrieved during this operation. You see it's +4 lymph nodes, and it's also the operation showed the improved disease-free survival. And also during these years, the possibility of minimally invasive approaches also have been shown for this operation. But at the same time, there are some limitations and disadvantages of RAMS. Of course, there are no significant reduction of postoperative pancreatic fistula rate, and to my opinion, it's no sense to wait the reducing, because the transecting of the pancreas is the same, and the few lymph nodes could be retrieved by minimally invasive approach. Some surgeons say that it's high technical complexity. This operation is of high technical complexity, and many of them said that it is impossible to perform it by laparoscopic approach, and possibly the volume of this operation is possibly excessive for T1, T2 tumors. And the main conclusion of many publications that no overall survival benefits could be seen after this operation. So if we conclude all these publications and conclude all these conclusions that are made in these publications. So the main thing that we should keep in mind that there is no differences in overall survival after RAMS and standard pancreatic resection. But at the same time, you see that R0 resection is better, lymph nodes retrieved are better, and disease-free survival is also a little bit better in these operations. So what concerning minimally invasive approaches, you see that laparoscopic approach reduces blood loss in this operation, but hospital stay, R0 resection are the same, and lymph nodes, as I said it before, is a little bit less by in average, less lymph nodes can be retrieved by laparoscopic approach. The robotic approach also demonstrates the same advantages and disadvantages, and the main limitations for robotic approach is that it's high cost, and to opinion of some authors, it's a longer institutional learning curve. So for today, we don't have any randomized controlled trials that are finished, who can confirm or not confirm the benefits of RAMS from the point of view of oncology. There is only one trial, which is now in progress. You see here it is. It's based on the experience of 15 German certified pancreatic centers, and we are waiting for the results. You see that one of the endpoint is disease-free survival at 3 years. So we're waiting for the results. Perhaps this work will show all the advantages, or perhaps some absence of advantages of this operation. And now I would like to simply to demonstrate several situations when we can perform RAMS laparoscopically in some difficult situations. The first one is the performing of this operation with celiac trunk resection. You see here it is the tumor of the body of the pancreas, and the celiac trunk is involved. And here all the principles of RAMS. We are following all the principles. Here is the transecting of common hepatic artery. we check the blood flow through the gastroduodenal artery all the time by intraoperative ultrasound. And then after we are sure that the blood supply of the liver is adequate, so we transect common hepatic artery and then perform the operation. Here you can see the damage of portal vein, and it was one of the limitations that is mentioned in the literature, that it is the technical problems of ramps is that these vessels may be damaged when we use antegrade dissections. Here you can see the illustration for it, and here you can see the illustration how these damages can be controlled also laparoscopically. They can be sutured, and here the final view of the operation. You see that all the principles of this operation here on the screen. You see superior mesenteric artery, portal, superior mesenteric vein, portal vein, left adrenal gland, and the upper pole of left kidney, which to the opinion of some surgeons is impossible to see by laparoscopic approach. So another situation is the tumor of the tail of the pancreas, which involved the splenic flexure of the colon. And here you can see that also laparoscopic approach can provide all the possibilities to perform this operation. Again, it's starting with the transecting of the pancreas at the neck and mobilizing it antegrade direction, transecting of splenic artery, mobilizing of the body of the pancreas, transecting of the splenic flexure of the colon. And here you can see again the final view of the operating field. It's kidney, renal artery, renal vein. So everything is cleaned, and the post-operative course of this operation is uneventful. And here another demonstration of tumor of the body of the pancreas, which with the tumor thrombin in splenic and portal veins. And the initial plan here was simply the super initial plan was simply to perform diagnostic laparoscopy, but then we see that it is possible to do it by laparoscopy. So we tried to transect the portal vein and to take off the trump from there, but we saw a little bit more adhesions than we expected before the operation. And you see one of the branches to the portal vein couldn't be controlled before this transection. So we need to change the plan right during the operation. So we resected this part of portal vein. You can see how we did it. So we need to change the plan during the operation. And again, it's simply the illustration that even in such unexpected circumstances, laparoscopic approach provide all the possibilities to finish the operation properly. So because the distance between the margins of portal and superior mesenteric vein were more than 5 centimeters, we decided to use prosthetic graft here. You could see how the operation is finishing here. The total blood loss for this operation was about 800 milliliters, and it's during all the operations. So post-operative period for this patient was uneventful, and you see that the final operation view of operating field is the same, to our opinion, like after open procedure. So in here we would like simply to show how preliminary results of short-term outcomes with distal pancreatectomy with celiac axis resection. You see that the median disease-free survival is about 18 months and overall survival 26 months. We think that for these tumors, these results are satisfaction. So we continue the gathering of the material, gathering of the patient, and invite everybody to participate in this study. So in conclusion, I simply want to repeat some things that I have said. So again, RAMPS provides standardized posterior retroperitoneal resection plane for performing proper from oncological principles, distal pancreatectomy, provide possibility for reduced blood loss for greater lymph nodes harvest. And we should keep in mind that overall survival benefits are not confirmed, and we're waiting for the results of this prospective study. We think that we will have these results in the recent years. And the minimally invasive approaches are oncologically comparable. It should be developed in high-volume hospitals who are specialized in pancreatic surgery. So here is our specialized team. in pancreas and here part of our hospital team. Thank you.
Thank you very much, Professor Katkov. A very nice review and impressive surgical videos. Do you have any questions from the audience, Professor?
Very nice presentation. Thank you. I have some couple questions. First is, do you have any experiences about DP car with robotic system? The second one, I know you have the two robotic platform, Da Vinci and Chinese. Could you any information about the Chinese platform? Yeah.
Oh,
And then I will continue.
Okay, so for today, we don't have any experience in robotic surgery in DP car operations. We perform it laparoscopically, and to my opinion, it is quite expensive to use robot with distal pancreatectomies because perhaps robot is useful, and of course it's useful for the surgeons who start to develop it from the very beginning. For suturing, it's the most advantages of robot is suturing. So you don't need suturing in distal pancreatectomy. So to my opinion, it's okay to do it laparoscopically. But of course, if it is possibility to use it, I mean, from the financial point of view, if it is possible for the hospital to use robotic system for distal, it's okay. It's very precise and you can use it, of course, but we don't have such experience. But concerning the comparing of robotic platforms, so for today we have 4 platforms. It's 2 Da Vinci XI, 1 SI, and this it's Chinese platform. I use it only for colorectal surgery sometimes. Very rarely, I never used it for pancreatoduodenectomies. Mikhail Ivanov is using in our hospital, has the experience of about 60 procedures, or a little bit more perhaps with robotic, but only in pancreatoduodenectomies. To the opinion of all our surgeons who use it for different operations, they are the same. They are the same, and one of our surgeons says that even Chinese platform, this Tumai, provides a little bit more frequency for, no, not frequency, more liberty for movements for the surgeons.
Okay, last question is about you did the vascular resection, portal vein resection, or arterial resection by a minimal invasive surgery. When did you start to do this kind of surgery after in the beginning?
So we started minimally invasive pancreatic surgery in 2007. We performed first operation in 2007, and we performed the first, I think, up to 100 operations in one team, in which very experienced pancreatic surgeon was involved. And the second surgeon began performing some part of the operation after 60 procedures. And the first venous resection we performed, I think that we had the experience about 50 or 60 procedures also. And for today, we didn't have a chance to perform minimally invasive arterial resections because I don't know our chemotherapists. They treat our patients so that they don't need this. And the tumor response is very good to chemotherapy, and we don't need to perform arterial resections. Or they simply can't treat it, and the disease is progressing, so we don't have such patients. But concerning venous resections, we perform it minimally invasively.
Okay, thank you.
Thank you.
Thank you. One more question, but
Dr.
the final one, please.
Professor, thank you for excellent presentation. I wonder, when you perform coeliac axis resection or Appleby operation, can you prefer a preoperative embolization to the celiac axis with interventional radiology? If yes, when is the time you preferred? And my other question for this issue, when you prefer the arterial anastomosis modified appleby, in which patients? Thank you.
So we don't perform any embolizations. We talk about this, but for this moment we didn't start it. But concerning blood supply of the liver, I said you that we check the blood supply during the operation. We compress the common hepatic artery, made it through intraoperative ultrasound, and in order to confirm that blood supply is adequate for the liver. So, and what concerning arterial anastomosis, we don't see any need for this because everything is working.
Thank you so much.
Thank you.
Dear colleagues, our next presentation for Evelyn Takarov, Bulgaria. Redefining standards is robotic Whipple, the new benchmark. Please.
Sorry for the inconvenience, but they lose my slides. Dear Mr. Co-Chair, dear colleagues, first of all, I would like to present my gratitude to the organizing committee and to the conference chairs, Professor Kerem and Professor Teshayev, for this kind invitation to be here and to share my thoughts about the place of the robotic Whipple in nowadays. Today I will discuss whether robotic pancreatoduodenectomy is becoming the new benchmark in pancreatic surgery. This is not simply a question about a surgical platform, it's a question about outcomes. As you know, pancreatoduodenectomy remains the most technically demanding abdominal operations, even in expert centers with high morbidity rates. Nowadays, this create an important question. Is it possible for robotic platform to overcome these issues and to improve the outcome? Before we ask whether robotic Whipple is the new benchmark, we need to define what a benchmark actually means. A benchmark is not just a technically impressive operation. It's not defined by the use of technology. A true benchmark should deliver better outcomes, or at least equivalent outcomes to the open surgery with safety, oncological adequacy, and cost efficiency, of course. A benchmark is not defined by technology alone. It's defined by measurable patient value. For decades, the pancreatoduodenectomy has been the gold standard. Laparoscopic pancreatoduodenectomy was introduced with the promise of minimally invasive benefits, but it has remained technically demanding, especially during the reconstruction phase. The Leopard 2 trial raised serious safety concerns, so robotic pancreatoduodenectomy emerged partly to overcome these disadvantages. As you know, the robotic platform offers several theoretical and practical advantages. First, it provides high-definition, three-dimensional magnified visualization that could improve the identification and precision during the dissection. Second, robotic instruments have 7 degrees of freedom. They make a thermal filtration and improve the surgeon ergonomics, but I'm not pretty sure after 6 or 8 hours of operation. So the strongest rationale in front of the robot is not the smaller incision, it is minimally invasive access without losing the reconstructive precision. If robotic pancreatodenectomy becomes a benchmark, the reason may not be the resection itself, it may be the reconstruction. The evidence is encouraging, but it's not uniform nowadays. The Europa trial was one of the first randomized trials that comparing robotic and open pancreatodenectomy showed comparable overall complication burden. The diploma trial after that shows the non-inferiority of minimally invasive technique. But the data are not univocal, so the landmark randomized controlled trials reach different conclusions, and the difference is explained by the surgeon experience and the institutional volume. As you see, in the early pioneering centers, reporting very long learning curve, sometimes requiring more than 100 cases. With the structured training programs such as LLabs 3, the learning curve appears shorter, with feasibility, proficiency, and mastery achieved in more controlled way. So the benchmark is not the robot, it is the robotic program. Without structured training, institutional volume, and mentorship, the robotic approach maybe worsen the outcomes, as previous speaker, Professor Baskur, shows in his lecture. A robotic Whipple should not be applied to every patient, especially in the early implementation. The ideal candidate is a patient with a resectable pancreatic head or periampullary tumor without major vascular invasion, or need of vascular reconstructions. But this does not mean that we couldn't implement the robotic program in the complex cases, but it will be becomes after some proficiency with this field. For pancreatic cancer, minimally invasive access is irrelevant if oncological quality is compromised. The essential oncological outcomes include R0 resection rate, lymph node yield, overall survival rate, disease-free survival, recurrence rate, and ability to receive adequate therapy on time. Currently, the clinically relevant postoperative pancreatic fistula is one of the defining complications after pancreatodenectomy. The evidence of fistula is promising, but mixed. Some large meta-analysis and propensity score match studies suggest a lower fistula rates after robotic pancreatodenectomy compared to the open one. Cost is one of the strongest arguments against robotic Whipple as an universal benchmark. Robotic surgery has higher initial cost because of the platform itself, maintenance, disposable instrument, longer operative time during the learning curve, and some training requirements. A robotic program becomes cost efficient after some steps includes increasing number of robotic procedures in one center and increasing expertise of the surgeon. There are strong arguments in favor of robotic Whipple procedure. It is associated with many studies with less blood, shorter hospital stay, fewer wound complications, lower delayed gastric emptying, and faster functional recovery. But there are also strong arguments against universal benchmark status. Robotic PD has a steep learning curve, operative time is longer, costs are high, especially in the adoption phase. Where are we now? Robotic PD is not longer experimental. It is well-established evidence-based surgical approach in experienced centers. As you see in South Korea, robotic pancreatoduodectomy accounts for more than 50% of all pancreatoduodenectomies in high volume centers. In the United States, it rise 3 times over the past decade. But benchmark status requires conditions. First, institutional volume is essential. Second, a learning curve should be not surpassed. And we need a structured educational program with mentorship, simulation training, and quality control. Now I will present you my thoughts based on institutional experience with more than 1,200 PD for 20 years period and personal experience with more than 300 PDs in the past 10 years. I start with mini-invasive pancreatic approach in 2020 with the laparoscopic Whipple procedures. I performed 12. There's no any conversion, but also I haven't observed any benefits for the patient in the postoperative period. And after the severe complication of my 12th person, I stopped to do this and start to wear the robot. Finally, we received the robot in 2025. Until now, I performed 15 robotic pancreatoduodenectomies, but I start to dream again for the laparoscopy. Why? Because according to me, major disadvantages in the robot platform for pancreatoduodenectomies are limited range of surgery, slow instrument change, difficult tissue holding and handling, monopolar domination, because I never use monopolar in the laparoscopic approach, and roof bipolar sealing device. The intuitive announced most precise bipolar sealing device, and I wait for it with patience. On the other hand, increased precision and dexterity improve the reconstructive phase of the procedure. This is the technique that I use at the initial part during the division of pancreas. I use 4 ports with the camera on the midline, and after that I do redocking with 1 port on the right for the next part of the surgery. As you see on the video, we start with mobilization of gastrocolic ligament and right colon, dissection of the lesser omentum and right gastric artery, followed by division of the duodenum. We proceed with cleaning of the lymph nodes along the hepatic artery, followed by a portal dissection and division of the pancreas. After these steps, I redock the robot 1 step on the right and proceed with the cholecystectomy, dissection of the duodenum, division of the ligament of triach from the right, and mobilization and division of the jejunum. After retroperitoneal dissection, finally, I transect the gastroduodenal artery and keep the common hepatic duct at the end, because in the last years we have a lot of problems with polyresistant flora after the bile duct stenting coming from cholangitis. So I transect the common hepatic duct with I'm ready for start to suture the hepaticojejunostomy. First, I perform hepaticojejunostomy for this reason that I mentioned before, and after that proceed with pancreatic anastomosis. For hepaticojejunostomy, I prefer interrupt sutures when the pancreatic duct, when the hepatic duct is small. I use 5-0 PDS for this. You see that the robot platform is really excellent for reconstruction, but till we reach this moment, I become really tired and nervous at this time of my initial experience. After the completion of this hepatic jejunostomy, we move to the pancreatic jejunostomy. I use double layer technique introduced by Traverso with posterior outer layer with V-lock, 3-0 V-lock, followed by ductus muscularis interrupt stitches, at least 3. I will lock the V-lock. I use Purdue drain, 3.5 centimeters, only 1 centimeters in the pancreatic duct and 2.5 in the jejunum. I put at least 3 interrupt stitches as ductus muscularis. And after that, we proceed with the anterior wall. In my initial experience with 15 robotic cases, we observed pancreatic B fistula in 2 patients. I manage it conservatively. We have no reoperation in this cohort of patients. I have 3 conversions, 20% of conversion. 1 due to the infiltration of superior mesenteric artery that I found during the transection. 1 for impossibility to take the jejunum from the right due to the dense adhesions on the left, and the second one was the need for total pancreatectomy after 6 hours. With the robot, I proceed with the open surgery. So, is robotic Whipple the new benchmark? My answer is not universally, not yet. However, in selected patients in high-volume centers, after the learning curve, robotic Whipple is becoming a serious candidate for the new benchmark in pancreatic surgery. But the most important message is that the robot itself does not redefine the standard. Outcomes do. A new benchmark must be safe, reproducible, oncologically sound, and economically justified and teachable. So robotic Whipple is moving toward a benchmark, but not at this time. Thank you very much.
Thank you. A good presentation. Who have a question, please?
Thank you for a great presentation with excellent videos. I'd like to ask if you are the only sole surgeon who is operating, because in certain centers, one surgeon does the resection, the other one does reconstruction. Being one surgeon can be tiring. And also, second question is, do you think following the first 15 cases, maybe having passed the learning curve, your opinion might change on the feasibility of the surgery? Thank you.
Thank you for the nice questions. In our hospital, we are 2 surgeons nowadays that we perform robotic Whipple procedures, but we do it by ourselves alone. So I do destruction and reconstructive phase by myself. Regarding the learning curve, I don't think that I overcome this learning curve. Maybe it will become after 13-5 case. So at this moment, I not feel very confident because I'm 20 years laparoscopic surgeon, and for me, the destruction could be made easily by laparoscopy. but robot is really helpful for the reconstructive phase. But I told you that I start to dreaming for the laparoscopy because during the destruction the robot is really slow, and I don't like to use small polar itself. Thank you.
The next question, Professor Mustafa Kerem, please.
Dr. Takaro, thank you very much. Very nice presentation and very nice videos. You have very huge experiences about the laparoscopic pancreatic duodenectomy, right?
No, I performed only 12 cases 5 years ago. I show it on the diagram. Between 2020 and 2022, I've started to do this, but after the 12th case, because of one rotation of the jejunal limb before gastrojejunostomy, I've received severe complications in my 12th case, disruption of the hepatic jejunostomy and pancreatic anastomosis. After that, I reoperate the patient, make the totalization of the pancreatectomy, new hepatic jejunostomy. After that, this patient takes a COVID and finally he dies. And after that, I stopped to do this bilaparoscopy, but I use it laparoscopy for distal pancreatectomies. I published one common hepatic artery approach to facilitate difficult cases. For me, the robot is beneficial for the Whipple procedures, especially due to the precise reconstruction after the operation.
Okay, thank you.
Thank you.
Professor, thank you for a good presentation. A talk, please. The next, your.
Sorry. May I ask a question? Yeah. So thank you for your honesty in your presentation. Thank you. Simply question. You said that you stopped performing robotic and going to return. No. And now you did I understand correctly that you are going again to return to laparoscopic?
No, I continue to suffer with the robot, but I think to perform another laparoscopic because due to this very difficult dissection phase with the robotic instrument.
I think about 10, 15 years ago, on one of the congresses, Michael Kendrick, one of the pioneer in laparoscopic people, said that you need to overcome the first 30.
Yeah.
I think it's the same for laparoscopic and robotic approaches. So, and do you
I'll
perform
continue.
robotic distal?
For robotic distal, I've performed 3 or 4 robotic distal just for experience in my initial learning phase. But for me, the distal pancreatectomy is more feasible by laparoscopy because you have better instruments and there's no need of reconstruction, so you don't need a robot for the distal pancreatectomies.
Any other questions, please?
Short comment. I would like, especially for the youngers, and this is one of the very rare example, and I would like to congratulate to Professor Takaro for his honesty. Professor Kato also managed it, but all of us on the congresses around the world will say, I'm doing this, I'm doing like this, I'm happy. So this honestly will, especially for younger, will encourage them. They will see that all of us are suffering. All of us are suffering. We are doing new procedures. All of us are suffering. We change procedures. So don't be afraid to suffer. It's a part of the surgical training and the part of surgical way. So that's therefore it's our job is so hard, but at the end of the day, all of us are happy. Even though you see, he looks very nice, he's suffering. Thank you very much.
Thank you.
Thank you very much. A good presentation. The next presentation, Igor Kratkov, Russia. Textbook outcome and patient reported outcomes, minimally invasive pancreatic surgery.
Thank you again. Thank you for invitation. Again, it's a pleasure for me to be here. And I would like to start with Dejan words that all of us are suffering from pancreatic surgery because it's quite difficult and complicated part of surgery. And I simply just when Dejan said these words, I remember that the first time I came up to Michael Garnier, who was the first to perform laparoscopic pancreatodonectomy. It's about, don't know, it's about 20 years ago, something about this, on one of the congresses, and asked, can I come to your hospital and to see how you perform this? He said, I stopped doing this. I'm a bariatric surgeon. So that's much more easy. But it's a very interesting surgeon. And our next presentation is devoted to some new highest standards and some to think about some possibilities to establish some highest standard in the results of this operation. And I would like to start with some of short history. We see even in this meeting that we are living in the era when minimally invasive approaches are introduced in pancreatic surgery more and more. And this is the reason to simply remember that the first operation was performed, as I said it just now, by Michael Garnier in 1994. Then Sir Alfred Kusheri performed also distal pancreatectomy, and both of them were not encouraged with a laparoscopic approach to this operation. The first venous resection was performed by Italian surgeon, Professor Haziran, in 2003. And after that, the first study was published not only from 25 laparoscopic procedures by French Professor Duluc. And after that, more and more publications we could see in the literature devoted to laparoscopic approach, robotic approaches. And the last one was published, is published in 2026. You see it's meta-analysis of 5,000 laparoscopic procedures. And all the guidelines, all the standards for this operation for today are finalized in two consensus conferences. One of them was in Miami in 2020, which said that all the approaches, open, laparoscopic, and robotic, are equal and should be the only thing that are equal in pancreatic surgery, and they should be developed only in high volume specialized centers. And minimally invasive approaches are also possible even in borderline resectable and locally advanced pancreatic cancer, again, only high volume centers, specialized centers. So for today, we think about perhaps some higher goal settings in enhancement of surgical results, because if you keep in mind the highest standards, some ideal outcome, I think you have more possibilities to achieve it. So to our opinion, there are two criteria for this. It's textbook outcome and patient-reported outcomes and quality of life. So several words about textbook outcome. It's the criteria which was introduced in colorectal surgery in 2013 and established some standards which we should achieve when we perform any type of surgery. In pancreatic surgery, it was introduced by the international group of experts. You see, it was led by Mark Besseling from Netherlands. You see here is the main criteria for textbook outcome in pancreatic surgery. There were also one of them was included a little bit later, and for today, postoperative pancreatic fistula, the estimation of postoperative pancreatic fistula, bile leak, hemorrhage, severe complications, it's more than 3 in Chlamydia classification, readmission in hospital mortality, and hospital stay. And for today, we can see some figures that illustrate the possibility of achieving the textbook outcome. You see that one of the publications shows that it is possible. It's about 60% in robotic, a little bit more in laparoscopic procedure. It's about 70 procedures, and one publication is more than 80% of textbook outcome by our Chinese authors. It's quite big figure, to my opinion, and that perhaps it depends that the number of patients is not very big in this study. So, and there is association because between the achievement of textbook outcome and the overall survival. You see that they significantly improve the overall survival for patients with pancreata who overcame through pancreatoduodenectomy, you see that the overall survival is better for the patients who achieved textbook outcome. So what about our experience? For today, it's the data for, I think, March of this year. We have more than 1,200 procedures. Minimally invasive procedures in our center. And among them, you see pancreatoduodenectomies, it's about 550, was about 150. Laparoscopic, 100 open, and the robotic is about 40. For today, it's about 60, I think, and closer to 600 by laparoscopy. But from this amount of operations, we analyzed, you see how many operations on the, we took all the patients in which we collect the full data for them and compared all the results from the point of view of possibility to achieve textbook outcome. All the groups were comparable by demographics data. We've seen gender, age, preoperative pancreatic fistula risk score, BMI, ASA, and so on. And intraoperative results, you can see it on the slide, and they were significantly different. You see that in laparoscopic procedure, blood loss in our experience is less than in robotic procedure for this first operation. And operative time is less. Blood loss is equal and conversion rate is also bigger for robotic procedure. And all these data are significantly statistically significant. Post-operative results, you can see it here. They differ a little bit, but the difference is not significant, statistically significant. Here you can see also the number of lymph nodes, there's zero resection, post-operative hospital stay, and the stay in the ICU is also practically the same, and there is no differences in them. So in our experience, we achieve the textbook outcome again about 60%. And you see the figure is a little bit better for laparoscopic procedure, but this is not statistically significant. And perhaps this trend is can be explained because we have simply more experience in laparoscopic approach than in any other of this. And for open procedures, we take more complicated cases. So if we put our attention on the difference, on the dependence of textbook outcome and overall survival, you see that the overall survival is a little bit better for textbook outcome patients, but these data are not statistically significant. But if we if you unite the textbook outcome in the group of patients who have good tumor biology, so G1, G2, and 0, and absence of vascular invasion, you see that we have better overall survival at 47 months against 17 months in this group. So it is very important to achieve textbook outcome to perform our operations with ideal result. What concerning patient-reported outcomes? Because, of course, we try, nowadays there is a trend also to provide the patient the most comfortable post-operative period. So we use RAS technologies. We don't try not to trouble the patients at any stage of treatment. So if we again put our attention to the literature, the publications, the number of publications who are devoted to quality of life and to estimation of patient-reported outcomes, you see it's very big, but among them, less than 1% are devoted to pancreatic surgery, and among these less than 1%, only 6%, so 72 publications, are devoted to quality of life of patients with pancreatic cancer who had surgical treatment. Here you could see the systematic review of the impact of pancreatoduodenectomy on quality of life in patients, where the questionnaire was suggested for this, and on the analysis of this literature data, we collaborated our question for our patients, and you see we made these questions for 40 patients who, in prospective manner, for open and comparing open and laparoscopic technique by patient-reported outcomes. There were 56 questions in 32 domains. And here you could see the results here. And I can comment it for a long time. You see that they're very precise questionnaire, which not only pain, nausea, fatigue, and there is also the question about social functioning, emotional health, and so on. But the most differences we saw in the difference in pain. So you see that during the first month, especially a patient who overcame laparoscopic procedures, they suffer from pain much more less cases than after open procedures, and also negative body image of himself. Also, it was better. The results were better for laparoscopic approach. And the thing that I want to pay your attention is that even future worries about the operation is much more less among the patients who are waiting for laparoscopic procedure than from among the patients who are waiting for open procedure. And all these criteria, they became equal in 3 and especially in 6 months. So after 6 months of the surgery, there is no difference in these groups at all. And you see that also these signs are much more better than before the operation for all the groups of patients. So, and in conclusion, I would like to say that in order to achieve these results, we should mastering in surgery, first of all, in HPB surgery, and improving our minimally invasive skills. It doesn't matter laparoscopically or robotic. It's up to the hospital and up to the possibilities of the hospital. But the thing that we need to create, it's that team of teams. It's not only surgeons and anesthesiologists, it's also gastroenterologists, interventional radiologists, clinical pharmacologists, which is very important, genetics, and so on, so on. And again, here is our team, big team, and thank you.
Thank you very much, Professor Khatkov, for this impressive lecture. Of course, minimally invasive approach is beneficial after the overcoming the learning curve at the beginning. Do you have some questions from the audience? If no, Professor Stojanovic, please.
Yeah, Stojanovic from Serbia. Thank you for your excellent lecture. You have a huge experience with minimally invasive surgery. Like you started with laparoscopy, and now you are doing robotic. What is, in your opinion, future directions in surgery, and some systems maybe between laparoscopy and robotic to overcome costs and etc. What do you think about handling system, Dexter system, or handheld instruments just for part of suturing? What's your personal opinion?
So it's difficult for me to make some personal opinion, because when we start robotic program, personally, I have quite big experience in laparoscopic procedure, and so for me, it's not difficult to switch in any directions, and I simply had big experience in it. So for me, it's quite difficult to move myself to robotic. I didn't perform any robotic pancreatoduodenectomy. I'm thinking about this, but I didn't do this because for me it's quite complicated. I do colorectal surgery. I think it's the most the best way. It's in the pelvic surgery, so but not pancreatoduodenectomy. And in these circumstances, I remember that Markus Büchler, his quite famous phrase that we have some demonstrations. To this, I can't believe in them, sincerely saying that it is cheaper, but perhaps it will be cheaper with. So I think that we need to do, and simply we live in such era that we will go there.
Yeah, thank you very much. We are just on time. Thank you for participation in this session. And finally, I want to invite speakers, chairs, and Congress presidents for one picture in front of the screen.
Dear colleagues,
I'm opening the session. First speaker, Emre Bozkurt. His topic is mastering complexity, defining and overcoming the learning curve in minimal invasive laparoscopic surgery. Emre Bozkurt.
Yes. Good afternoon. Thank you, Professor, for invitation. The topic of my talk is mastering complexity and defining and overcoming the learning curve in minimal invasive liver surgery. Especially mostly I talk on robotic liver surgery throughout my presentation. I also include some comparisons of robotic and laparoscopic approach. I have no conflict of interest. Robotic liver surgery is rapidly expanding worldwide. It's no longer experimental and it's becoming standard in many centers. And at the same time, we are taking on increasingly complex and technically demanding cases, and importantly, indications are evolving. And cases once considered unsuitable for robotic surgery, now being revisited and successfully managed robotically. So ultimately, this is not just about a new technology, it's about how our limits are shifting to robotic side. So when we look at what are the limits, it's not just about technical. Technical factors still matters like anatomical access, tumor location, bleeding control, and capability of the robotic platforms. But there is also the other side, the oncological side of that platforms. And we must always ensure the adequate margins and also the long-term outcomes. And importantly, many limits are actually human and institutional related factors. Those are the surgeon experience, hospital facilities, intraoperative judgment, team dynamics, and case volume. But these limits have clearly evolved over time. From the first robotic segmentectomy in 2006, we have moved toward the major hepatectomies and complex resections, and even exploring areas like transplantation and ALPS in the robotic setting. And this historical background also in line with suggested step-up approach, like starting from the segmentectomies or wedge resections to more technically complex cases. And evidence on robotic liver surgery have significantly increased over time. And today they account for approximately 35 to 40% of overall liver surgery literature is the robotic liver surgery. For the patient selection period, factors such as age, obesity, tumor size, previous liver surgery, previous abdominal surgery, child age cirrhosis, two-stage hepatectomies, hepatectomy after liver volume modulation, and relationship with vascular structures are no longer absolute limit. The key determinant is whether the patient is an appropriate candidate for minimally invasive surgery overall. And when we look at the learning curve compared to laparoscopy, robotic liver surgery offers a shorter learning curve driven by simulation-based training and advanced technology, which enables a more rapid expansion of indications. Here you can see the numbers that the learning curve for robotic, you should do 28 minor resections, 15 anatomically measure, and 54 technically measure. It's much more for the laparoscopic cases. And commonly mentioned advantages are enhanced ergonomics and stability, no tremor, better needle control, and less fatigue. And those ultimately improve precision and safety in complex liver resections. With lower conversion, less morbidity and blood loss, and comparable oncologic outcomes, robotic surgery goes beyond the facilitation. It actively enhances patients' outcome also. Here's another example from Professor Skandi's study showing less blood loss, lower conversion, and shorter hospital stay reinforcing that robotic liver surgery is expanding across the spectrum of indications in the right setting. And this is then another comparison of robotic and laparoscopic liver resection in ordinary cases. And the authors conclude that compared to standard cases, the advantages of robotic surgery become more pronounced, especially in complex setting. And here you can see robotic surgery cases in different settings. This is an colorectal liver metastasis patients at liver segment 2 and segment 7. We completely mobilize the liver right and left side. We also do the Pringle preparation. We are not routinely applying Pringle, but we do preparation for all cases. And check the lesion with intraoperative ultrasound. For Pringle can be done to manipulate externally by the patient-side surgeon, or on the surgical field, it can be manipulated by the surgeon. For complex cases, it is suggested to done externally manipulated from patient-side surgeon to allow operator not to leave operative field during the emergent situations of the surgery. If a sudden bleeding occurs, a surgeon should leave there and go to do Pringle and then come back. So it's not useful to do from the surgeon's side. And here you can see another example of retrohepatic dissection. This is a patient with segment 7 cystic lesion, and we check the lesion with the intraoperative ultrasound and make a proper plan for resection. Also, the minimal invasive, the robotic surgery setting allows us to use some technological steps like ICG usage and also the intraoperative ultrasound implementation. And this is an example of an ICG usage. This is a patient with the colorectal liver mets that is located at the left portal pedicule, on the left portal pedicule, and it has obstruction in the bile ducts of the left hemiliver. And we prefer to do left hemihepatectomy for this patient. We first work at the hilum, and we we made the section from gate 1 to gate 3, hang there, and we put a bulldog clamp there, and we applied ICG, intravenous ICG. And we see the demarcation line here clearly, and this is the resection site for left hemihepatectomy. And the video on the right-hand side is another example. This is an extremely rare case of a secondary liver tumor. This is a solitary fibrous tumor metastasis from the central nervous system. Patient is 32 years old, and he had operation of cranial operation 6 years ago. He has 5 lesions, 2 in the left lateral section and 3 in the right hemiliver. I do left lateral segmentectomy with 3 metastasectomies on the right side with robotically under the guidance of the intraoperative ultrasound. So the technological advantages provided by robotic surgery directly enhance the surgical precision, we can say this. And for comparison of the robot versus laparoscopy, this is a good paper. It includes the 10,000 patients and 1,500 patients in the robotic liver surgery group and 8,500 patients in laparoscopic liver surgery group. They compared the achieving textbook outcome in different settings, robot versus laparoscopy. They defined the textbook outcome as there is no intraoperative complication bigger than grade 2, no bile fistula, no severe morbidity, no readmission, no in-hospital or 90-day mortality. And also they define a textbook outcome plus as a no prolonged hospital stay. And they compare 2 groups. In the robotic group, the patients achieved more textbook outcome and also less usage of Pringle, less blood loss, less conversion, and general morbidity is less in the robotic group. Also, they do compare the minor resections and major resections setting, the robotic and liver laparoscopic surgery they compared, and in the major resection settings, the achieving textbook outcome in the robotic group is much more pronounced. So robotic has much more advantages in the major resection setting. And this is another example, the last video, that this is a cystic lesion in the left lateral section of the liver. It's 12 centimeter in diameter, and patient had several times of infectious complications and emergency department. And for this case, also I usually prefer in the suitable patients, of course, the extrahepatic glycine approach. I create a hole from gate 1 to gate 2 to find the left lateral pedicule, and then I staple it and just directly go to the vein and put one more staple there and complete the left lateral sectionectomy. Thank you.
Thank you for your nice presentation. Any question? Yes, please.
Thank you for your nice presentation. I have two questions. First question, both related to technical issue. First question, how you decide to do metastasectomy or formal liver resection? This first question. Second question related in the cyanin green. Do you think in the cyanin green test is mandatory for laparoscopic or robotic surgery?
In the cyanin, I will start from the second question. In the cyanin green usage actually facilitates the surgery. Every time in the surgical step, you can open the ICG mode and then you can check your resection plane if it is smooth. Otherwise, when you do it, you can just, when you do it without ICG, you just see a ischemia margin on the surface of the liver. But when you go deeper, it is hard to follow the same line. Sometimes you can mix your line during the later stages of dissection. For the first question, for secondary tumors of the liver, especially for the colorectal liver metastasis, I usually prefer parenchyma sparing surgery. For those cases specifically, I preferred left hemihepatectomy because the lesion is located on the left hepatic pedicule and also obstructing to the bile ducts of the left hemiliver. There were also shrinkage in the left hemiliver of that patient. So I preferred left hemihepatectomy for this.
Thank you. Yes, please. Raja. Just a moment.
Efendim, beni bu son demonstrasiya elədiyiniz hastanın aqibəti maraqlandırır. Orada patahistaloru nə təsdiq olundu?
Malignite değil. There is no malignancy at the cystic lesion. The last video, it's a benign disease, but it's symptomatic, like it's compressing the stomach, and also the patient admitted to the emergency department several times for infectious complications.
Teşekkür ederim.
Any other question? Thank you. Thank you, Emre Bozkurt.
Thank you.
Second speaker, Mikhail Efenov, benchmark criteria for robotic resection in patients with perihilar cholangiocarcinoma.
Dear Mr. Chairman, dear colleagues, thank you again for the honor to be here and to share our experience in robotic surgery for perihilar cholangiocarcinoma, where we used textbook outcome analysis in order to define which benchmark criteria, or in other words, selection criteria may be used for maybe starting of the program for robotic surgery or to select patients for better results. We have nothing to disclose. Radical surgery for pericardial cholangiocarcinoma remains challenging procedures. That is why the vast majority of patients still treated by open approach, and the adoption of robotic surgery for pericardial cholangiocarcinoma is progressing slowly, with steady but quite slow increasing of annual number of papers published and presenting the analysis of robotic surgery for pericardial cholangiocarcinoma. That is the dynamic of robotic and laparoscopic surgery for liver and bile duct malignancy in our department. Orange bars is robotic cases, green bars is laparoscopic. Despite the upward trend and increasing annual number of minimally invasive surgery for malignancy, for any type of malignancy, you see that the ratio between robotic and laparoscopic resection remains stable. Around every fifth patient was treated by robotic approach. What was the reason? The main reason for that is our belief that robotic complex should not be applied for any type of liver resection, maybe for pure liver resection, but mainly for combined liver resection and any kind of reconstruction. First of all, biliary resection and bile duct reconstruction. This concept was realized in the surgery of pericardial cholangiocarcinoma. You see the increasing proportion of robotic procedures, orange bars comparing to blue bars, open resection, especially over the last 4 years. You see that in 2024, the proportion reached 68%, and enormous for us as well, but that is a fact. And we reduced this proportion the last year, but it depends on the cases. By March of this year, around 400 of cases of robotic resection for pericardial cholangiocarcinoma were presented in literature, presented in 48 reports, but only 8 studies presented comparative analysis of robotic and open procedures. That is the largest until the last year Western multi-center comparative study, which analyzed outcomes of 38 patients treated by robotic approach with open procedure, and authors justified the advantages of robotic approach in terms of blood loss, in terms of postoperative morbidity, and length of hospital stay. Their median survival was not reached for robotic approach, but this study has its own limitations. There were no PSM, propensity score matching analysis. There were no any data on TNM stages, so we don't know which patients for which study were operated by robotic approach. High proportion of bismuth type 1 and 2. Every third patients was treated by robotic approach with 1 and 2 types. According to bismuth classification, and relatively short follow-up period, around 15 months. That is our study, which was recently published in Korean Journal of HPB Surgery, where we analyzed 41 cases, which were matched with 82 1 to 2 open resection. When we compared outcomes of patients who was treated by robotic and open approach for bismuth type 1 and 2, and with early TNM stages, we found that after PSM analysis, the differences in survival were close to significant. Anyway, you see that all patients treated by robotic approach were alive. That is why we concluded that in patients with bismuth type 1 and 2 and early TNM stages, robotic approach can be considered as a reliable treatment options comparing to open approach. We test this hypothesis in our latest series. We analyzed textbook outcome achievement in 50 patients treated by robotic approach, and we compared 162 patients treated by open approach. Due to selection of patients for robotic approach, in robotic group, there were There were less number of comorbid patients. Patients were treated for less advanced tumors in robotic group. There were less lower rate of preoperative biliary drainage, and there were a lower rate of vascularization. But interestingly, that despite the selection in robotic groups, there was quite low low number of isolated bile duct resection. We tried to perform the standard option like major hepatectomy, irrespectively to the approach. The textbook outcome model included Haziran resection, no severe morbidity, which was defined as more than 3A clavien complications, no 90-day readmission, no 90-day mortality. We performed the logistic regression analysis in order to define which negative predictors of textbook outcome we should use for to define the benchmark group. We found that two of them, macrovascular invasion and severe cholangitis, according to the Tokyo guidelines, had independent negative influence on textbook outcome achievement. These criteria were used for allocation patients in group of different surgical risk, and benchmark group presents patients with the lowest surgical risk and the most favorable surgical and oncological prognosis. These two factors help us to allocate patients in group 1 without any predictors. Group 2, the second group with patient had only one negative predictors, and in group 3, all patients had both predictors. So the group 1 was defined as benchmark group with the lowest surgical risk. Between groups, patients had significant differences in bismuth type 1 and 2, advanced tumors in rate of biliary drainage, and complication related to the biliary drainage before surgery. And what was interesting, there were no vascularization, respectively, in the group 1, and all isolated bile duct resection without liver resection were performed also in group 1. We compared outcomes of robotic approach and open procedures within every group, and in benchmark group, we found that patients were treated for less advanced tumor, but surprisingly, the patients in group 1 treated by robotic approach had higher frequencies of lymph node metastasis. The outcomes were better, expectedly better in robotic group, less morbid patients, lower value of comprehension complication index, high rate of textbook outcome achievement, and shorter ICU duration stay in ICU. But of course, the length of duration of operation was expectedly higher in robotic group. No conversion were performed for open surgery in group 1 in benchmark group. There were no differences in overall and disease-free survival. It may be a little better overall survival in robotic group, but please pay attention to the distribution of TNM stages, and metastatic lymph node lesions were not in favor of robotic group. It was in favor of open procedures. So that is why this plots of survival quite promising for robotic approach. In group 2, where patients had one of the negative predictors, again the patients in robotic group were still treated for less advanced tumors, but patient had more rate of severe cholangitis before surgery in robotic group, and we performed with difference more close to significant, more often major resection in robotic group and extended resection also in robotic group. The preoperative outcomes were the same in these two type of approaches, and but in this group, in group 2, every third patient was converted for the need to portal vein reconstruction, because we just not confident in this type of procedure by robotic approach. Performed by robotic approach. Again, there were no differences in overall in disease-free survival between types of approach. And last is group third, the most challenging group. There were no differences in preoperative data. And please pay attention that only 8 patients were treated by robotic approach. It was highly selected patients with advanced tumor. In opposite, 47 patients were treated by open approach. No differences in perioperative outcomes. Again, the average third patients was converted for the need to perform portal vein reconstruction. The worst survival, but the patients were the most complex in terms of advanced tumor. But there were no differences between approaches. And in conclusion, I dare to say that robotic approach is associated with better immediate outcomes if we have no any negative predictors of textbook outcome achievement or overall negative predictors of worse outcome of surgery and oncological worse outcome. But these predictors are usually associated with bismuth types 1 and 2 and early TNM stages. That is why this criteria may be used as selection criteria, benchmark criteria for robotic approach, especially in the beginning of the program of robotic surgery for this quite complex type of patients. Surgery. Roboticization was not inferior to open approach in advanced tumor, but it should be highly selected patients, so we need for further evaluation of outcomes. And vascular invasion still remain the only, maybe the main contraindication for robotic approach in our experience. But let me demonstrate our last cases. It is a Hepato PD. We performed pancreatic duodenal ectomy with left hepatectomy and marginal portal vein resection. That is the final view of operational field. The segment 1 was preserved because of the type 1, according to bismuth, the sutured portal vein. The passage of the blood flow was preserved. Soft stump of soft pancreas with narrow, quite complex postoperative course, but without very complex, very difficult complication. We managed we manage with them by percutaneous approach. Thank you for your kind attention.
Thank you for your presentation. Please, questions. Yes.
Mikhail, congratulations, very good, huge experience. What I'm wondering is, I couldn't see any patients with a disease bismuth 3A and 3B. What's the reason? Because 3N and 3B, in my practice, they are two, most frequently encountered patients which are deemed resectable.
You mean that there should be the difference between 3A and 3B, but we combine this.
I see bismuth type 1, type 2, and type 4.
Yeah. Okay.
Where are 3A and B?
Okay. You're right. That 3A is a little bit more complex, but in the past, for us, the complexity of the surgery depends much more not on the type of the tumor. Of course, it's sometimes it's easier to perform surgery for type 1 and 2, but at this stage of mastering in this technique, we believe that the most limiting factor is vascular invasion, and you should be confident that that you will manage with involvement of all vessels in tumor when there is no true tumor vascular invasion, because in some degree the artery and portal vein involved in tumor. Maybe every cases on every third cases, every second cases. That it's not easy to explain, but vascular relationship with the tumor, that is the main, not A, 3 bits like the same for us. Sorry if I.
Thank you. Thank you for the great presentation. I'd like to ask your opinion on an issue. On receiving a textbook outcome, you need to have a good selection of patients, because certain patients, you have a prediction of failure of textbook outcome, such as a patient with frailty, sarcopenia, perhaps cholangitis, portal vein involvement. But this brings another issue with itself. So once you become very selective, on the other hand, you're a referral center, tertiary center. So this brings a question to my mind. A patient who didn't have a textbook outcome, but happened to survive 5 years post-operatively, I think that's still a success. So what do you think on this topic? Do you think on a topic of perihilar cholangiocarcinoma, this textbook outcome, is it a good measurement? What do you think on this?
Thank you. Very important question, very nice. Because you touch very complex problem. You should have a matured program of helping the patients with any type of biliary malignancy. It doesn't matter, perihilar cholangiocarcinoma, gallbladder cancer, or maybe it's intrahepatic cholangiocarcinoma, so-called portal type with invasion of the hepatis hilum. You should prepare like a rehabilitation. You should know what you should do, and final decision which patient could be treated by robotic approach should be made in our opinion again with the main attention to the vascular involvement. Because if patient is stable, there is no any nutrition disorders, there is no cholangitis, because it's also very difficult problem to, you see that more patients were treated by robotic approach with cholangitis, but we prepared this patient. It can take months or 2 months. It is long time and difficult work. A lot of percutaneous in the biliary drainage, replacing stents, replacing, but the final decision that a vascular invasion for us just now.
May I ask a question? Thank you very much for this nice section. It's very impressive experience. I have one suggestion and two questions. Bismuth classification doesn't mean anything about the resectability. This is just a topographic information about the bile duct infiltration. My suggestion would be for a benchmark study. It's very impressive to use other staging systems like membrane long catering staging, or this new from Switzerland, from Pierre-Alain Clavian, Nimur and Neuhaus suggestion. These new systems, they are providing more information about the vascular infiltration. And for a benchmark study, for robotic surgery, it will be better, I think, to use these systems. This is my suggestion. And two questions. Those are central tumors. I think you prefer, in many patients, the left-sided resections. Is that true?
Yeah.
And it's more complicated about the bile duct reconstruction.
That's right.
Why do you prefer left-sided resections? And my second question is, do you perform mandatorily caudate lobe resection in those?
Yeah, thank you. Very important questions. Again, I should repeat. I should repeat that we should not be dependent on the level of bile duct resection. You should follow by the clear surgical margin, and if you need to perform high level resection, you should do it. It doesn't matter how orifices of the bile duct you should reconstruct. 5, please do it. But the surgical margin should be clear. Much more difficult to release the vessels again from the fibrotic adhesions, peritumor inflammation, and you should be confident that there is no true through tumor invasion. I'm not sure that any other classification, like you mentioned, Clavien, Memorial Sloan Kettering Center, maybe they're helpful for any centers, but it's much more important to see properly the CT scans and bile duct images. That is help you. But in last cases, maybe last two, the last 20 cases, we use spyglass. But we found, surprisingly for us, the spyglass is not enough to be confident about the level of the tumor. It's also maybe wrong. But the last case I demonstrated was the undurned spyglass, and the spyglass told us that there is no any tumor. But we found tumor with vascular invasion. It's quite complex. You should be ready to perform, maybe to convert. You saw that converted cases, every third patient in advanced tumors. Yeah, in robotic group, 94%, almost every patient. That is the exclusion.
Thank you, Professor. The vascular invasion is a limiting factor, but you and also the professor presented so many very well managed vascular resection and reconstructions, even in laparoscopic settings. So for the cholangiocarcinoma, why we are saying that it's a limiting factor if there is vascular invasion? Because it can be managed easily with robots also. What's your opinion?
The main obstacle in the wide adoption of vascularization by robotic approach, for me, maybe for the rest of the surgeons who are involved in this area, that is a short stump, distal stump, and you should have a space to put the bile duct and to do it confidently, and to have a space for suturing. That's it's possible for cases to bismuth type 1 and 2, but if there is 3A or 3B, the stump may be very short, and it's quite difficult to release this stump, distal stump, I mean, to perform the anastomosis in open surgery. In robotic surgery, you should be less confident, because that is also learning curve. Maybe in the nearest future or far future, we will do it.
Thank you. Any other questions? May I also ask a question? Are you ready to make some concrete recommendations for using a robot for this pathology?
Thank you. We prepared to that, because it was a very important question that bothered us. What patients should be treated, may be treated by robotic approach without dangerous to the patient and without compromising the oncological outcomes. We try to find the exit to the decision, and one of the way to make this decision was using the textbook outcome benchmark criteria, using their negative predictors. I'm not sure that that is the right way, but it's helped us to create a benchmark group, and the outcomes in the benchmark group were much more better than in other ones. That is why that is the way. Maybe, but that is published, and maybe it's also it's already there some kind of recommendation.
Thank you. Thank you. The next talk is also by world well-known surgeon from Turkey, Mehmet Fatih Khan. Please.
Dear chairmen, dear colleagues, thanks again the organizing committee to give me this opportunity to present our results here. Our total case of laparoscopic and robotic liver surgery is like 150%. I want to show you a totally purely video-based presentation here. Let's start with the hepatic vein bleeding from hepatic vein during laparoscopic liver surgery. As you see here, we have a hole here, just here. So when sometimes we can encounter such a bleeding at the very beginning of laparoscopic liver surgery. This is a misperception of anatomy, and we mistaken for the hepatic vein as a vena cava. So we need to start beginning of the procedure. We need to repair the vena cava. There's a 1 centimeter hole in the vena cava, so we should be keep calm first, and then we can use in a 2-0 vicryl stitches. We can repair it, but the most important thing during such a surgery is be able to keep calm, of course, because panic may worsen the situation in this condition. So again, a portal vein injury sometimes may happen sometimes during laparoscopic liver surgery. Here when we cut the hepatic artery, we accidentally cut the portal vein. A grasping with a grasper, handling with a soft grasper, not a sharp one, but a soft grasper, temporarily control the bleeding, and then we can place a clip, hemlock clip, first proximal, then distal to the injured area. When we encounter such a bleeding at the beginning of procedure like this, if we are not prepared for a repair, and if we are not easily handle the bleeding, a compression, again keeping calm, and a compression with a gauze can give us a time to be prepared, and stitches, and maybe asking for help from a colleague during surgery. If you have a bleeding from hepatic arterial system or celiac trunk like this, actually this is an example of when we need to convert to open. So an experienced surgeon can try to fix it, bleeding from the such a stump of artery. But things may sometimes worsen during fixing on passing the stitches there. And this is, I believe, the time to open surgery, be grasping the bleeding area, asking for help from a experienced colleague, and open the case to complete the procedure in a safe manner. So we don't hesitate to convert to open during such a bleeding. Hilar plate, we know has a rich vasculature, so hepatic arterial bleeding can frequently occur during resection, like on this. So we don't need to scare this. If we control portal vein, hepatic arterial bleeding stop easily in a few minutes. How about surface management? After completing the resection, hepatectomy, surface management an important point. We sometimes use argon laser coagulation, and sometimes some chemical materials to control the surface, small surface bleedings, as we can see here. Oxidized cellulose also works well in this situation. Small bleedings from short hepatic veins can control easily with just clipping. This may happen at the end of, almost at the end of a resectional procedure, and clipping works here. Many times we need to manage the step line because sometimes we use, purple cartilage, sometimes green cartilage, according to the, edema on the hilar plate where we put the stitches. Clipping, sequential clipping may work. If it's a, some area where we need to be more gentle, then interrupted stitch like 5-0 Prolane or 6-0 can be used as a to fix the bleeding problems and bile leak during laparoscopic liver surgery. But bites should be very, very small. Large bites may obliterate the common hepatic duct there. So after this, I want to show you some good handling of hepatic vasculature during laparoscopic liver surgery. Short hepatic veins should be gently approached all the time during laparoscopic liver surgery, because at the beginning of procedure, if we encounter a bleeding from this side, so it may sometimes very difficult to control. So gentle, soft dissection is necessary. When it comes to intrahepatic, intraparenchymal hepatic vein management, so we mostly use such dissecting devices to pass behind the hepatic veins here. This is a middle hepatic vein. We tape it, clip the tape. This is another middle hepatic vein during ALPS procedure. Again, taping, handling, and clipping. So the right hepatic vein is a anatomic vein. It's very, very sometimes be dangerous to dissect behind. So we need to be very careful during dissection behind the hepatic vein, right hepatic vein. Here, there's another example where we are operating around the right hepatic vein. We mostly use a stapler to control closure of hepatic vein, but if it's a small one, then two hemorrhagic clips can be used to close the stump of right hepatic vein. Again, hepatic artery. Hepatic artery, again, should be approached gently, because any damage to its wall can cause late bleeding days after surgery. So it's very much important to not too much peel off the hepatic vein during hepatoduodenal dissection. If we need to grasp the hepatic vein, we need to be very gentle. And we need to use some soft grasper devices. It's a big tumor invading the right hepatic artery from its origin, coming from the proper hepatic artery. Big tumor invading the segment 6 here and 5. Yeah. So the hepatic artery is not a very paired anatomical structure if we approach gently during dissection. another handling of hepatic artery. The next one is portal vein. You know, this is an annoying vein which we need to handle at the beginning of the section. After tying this, we can more easily approach the right hepatic vein as we see here. And we can tie it or ligate it with a hemlock clip or using a stapler. Our preference at most of the time is using hemlock clips, but our policy is to place at least 2 hemlock clips sequentially to safely close the right portal vein stump. This is approach to left portal vein. As we know, the left portal vein is longer than the right one, and we can easily place a vascular stapler to close that. This is a case of laparoscopic ALPS procedure where we need to circle the right portal vein, ligate it, and cut it. This is another laparoscopic ALPS procedure. Here, there's a anatomical variation. This is right posterior portal vein. We can easily circle, tape it, and clip it. But the problem here is that the right posterior portal vein, it comes from the left portal vein. So we need to perform a very deep dissection around the left portal vein. It's dangerous. So we first perform the Pringle maneuver, then tape it, and then clip that. And a parenchymal transection. A parenchymal transection is much more straightforward during laparoscopic liver surgery. We typically use CUSA and harmonic scalpel, mostly together to device. Recently, we started to use harmonic scalpel much more frequently. If we dissect around the hepatic veins, we still use CUSA, but most of the time we can complete all parenchymal transection during hepatectomy only using harmonic scalpel. As you can see here, harmonic scalpel is a safe device to proceed during hepatic parenchymal transection, if you can use it as a CUSA device. Okay. We frequently use staplers during laparoscopic liver surgery. Stapler is a very, good device to close large hepatic veins and portal veins. We mostly use vascular cartilage, but sometimes if the tissue is very edematous, then we can use purple cartilage stapler. Bile duct repair is something that we need to handle, a problem that we need to handle sometimes from time to time. But during intraparenchymal bile duct repair, we need to be very, very careful to not to obliterate vital hepatic parenchyma. So as this is another example, we have a leak here, bile leak, but we need to be very careful. This is a 5-0 Prolane stitch. If we take large bites, we can occlude left-sided bile duct completely. We use oxidized cellulose at the end of the procedure almost always. Thanks for your attention.
Thank you. Any question? Yes, please.
Thank you for the presentation. I would like to know how is your clinical practice in minimal invasive surgery for central venous pressure? I mean, do you always routinely try to stay under like 5 or? I mean, I would like to know your clinical practice.
Okay. During laparoscopic liver surgery, our intra-abdominal pressure is 14 millimeter. But if there's a bleeding, significant severe bleeding, especially from hepatic veins or vena cava, we temporarily increase the intra-abdominal pressure to sometimes up to 18. We also tilt the patient, bring him or her to triangular position to prevent gas embolism. And then we can easily fix the, as I showed you, demonstrate here in vena cava injury. So there we increase the intra-abdominal pressure to 80 temporarily. But should be short time, because if you increase the intrahepatic abdominal pressure for a long time, then kidneys may compromise.
And if you let me one more question, do you always routinely perform Pringle maneuver? I mean, do you always make the preparation for that, whatever, in every situation, in resection?
Okay, it depends on the resection that we will perform. If it's a small metastasectomy or a small, for example, small resection from segment 3, no. But including all segmentectomies, sectionectomies, and larger hepatectomies, we always use Pringle, and we prepared in advance.
Thank you.
Congratulations. Very, very impressive presentations. Your measure. Let me, maybe it's not a question per se, but it's like a comments, but maybe you have an answer. What do you think about goal-directed therapy? Because our hepatic surgery is a teamwork with anesthesiologists, and in our hospital we ask them to restrict patients in fluid overload, avoid overload. And in these cases, we usually don't increase. We drop down paradoxically drop down abdominal pressure, because there is a relation between the abdominal pressure and the pressure in IVC. And the first step we do, we try to decrease the pressure in our ways, drop to 0 PEEP. Maybe the marginal decision is to stop ventilation, maybe for some seconds. You reduce the pressure in IVC to the 0, maybe to the minus, and there is the best option is the window, very short in time, to make a suture. Maybe you have some practice, but it depends on. But it's not so easy for anesthesiologists to maintain the arterial pressure at that moment. And then the second one, comments question. I agree completely with you that harmonic scalpel is the best device for maybe sometime better than other one. For parenchyma dissection, but we use not ultrasound tips. We use like bike lamp. It's very, very nice. What is your opinion?
Okay, Mikhail, thank you. Restricted fluid regimen is necessary in every case of laparoscopic or robotic liver surgery, I believe. Always. We ask our anesthesiologist to keep cava pressure, central venous pressure, around 0 during all surgery. and we encourage them to start vasopressors if necessary. Please don't load patient with fluid. If necessary, please start vasopressors. I agree. When it comes to bleeding, actually, our policy is to increase intra-abdominal pressure temporarily, and trend the lumbar position a bit. This way, we can easily control massive bleeding and also limit gas embolism. So carbon dioxide gas embolism is not too much feared problem, as in, opposite to an open surgery. Opposite. And using this, we can easily, stitch the hole, close the hole, or clip the hole. And this most of the time takes only 5 minutes or 7 or mostly 8 minutes. So it's not a big problem. When the second one, the harmonic scalpel, very good device. Now, in most of the cases, I don't use CUSA actually. Minor resections.
Even in cirrhotic patients. Even in cirrhotic patients.
Yes. But you have to be able to use CUSA like harmonic like a CUSA, like this. This is very important movement during parenchymal transaction, I believe.
Excavation, like it was Gora Honda term proposed. Thank you so much, Michael.
Sure, please.
Please, may I ask you, thank you for your presentation. You demonstrated very good technique in controlling of bleeding. My question is, did you have conversions because of bleeding?
Of course.
What were the reasons?
Of course. As I demonstrated here, if we have a bleeding that we cannot control laparoscopically or robotically during Hepato Pankreato Biliary surgery, we convert to open. Our conversion rate like 8-9% in general in HPB surgery. Mostly, we have two reasons for conversion. First, a bleeding that we cannot control minimally invasively. The second one, inability to proceed due to adhesions, edema, fibrosis, or bleeding.
Thank you.
Now, is there any other question? I wish to invite Igor Katko to the stage to present his plaquette because he is leaving after the session. Thank you.
Вас поздравляю и благодарим за то, что вы видели время, свое ценное время и приехали сюда, демонстрировали нам свой опыт по данной хирургии и за то, что вы вот так нам сегодня показали свое мастерство и результат своих исследований, за участие, за презентации. Вручаем вам сертификаты и для участия, и по докладу. А также небольшой приз, подарок подарок на память от Узбекистана. Здесь вот Самарканд и Ташкент. Тоже необычное. Здесь Ташкент, а это Узбекистан. А также что будет Oh,
So thank you very much. It was great pleasure, and this great pleasure and honor for me to be here. My congratulations to Mustafa and the organizing committee. It's great conference. And Mustafa said it's really great pleasure for me to be here because I was born here. So thank you, in Taşkent.
thank you very much.
A small gift from Turkish HPP Surgery Association also. This is our official tie. I think it fits with your suit very well. Thank you very much for your contribution.
Большое вам спасибо. Будьте здоровы. Успехов в работе.
Спасибо большое. Thank you.
Now coffee break, and we will come back in 15 minutes time.
Как лечение метастазированной печени при колоректальном раке. Докладчик Recep Erçin Sönmez. Тема выбора времени хирургического вмешательства при метастазированной печени при колоректальном раке. Этап подхода.
Hello. Good afternoon, the chairman and the colleagues. First of all, I would like to thank you for the Congress President and the Secretary for their kind invitation. Today, I'm going to talk to you about the surgical timing in synchronous liver metastasis. By the way, I cannot see the presentation here, but the timing matters in the management of synchronous colorectal liver metastasis. I cannot see the screen yet. No, it's not working. Devam edebilir miyim? Devam edebilir miyim? Yes. So I'm going to discuss about the surgical timing in synchronous colorectal liver metastasis. I'm going to give a brief presentation about the stages, the different surgical strategies. So the timing matters in the management of synchronous colorectal liver metastasis. It matters because synchronous liver metastases are common, fairly common. They constitute about 15 to 25% of those patients. And but unfortunately, only a minority of those patients have the chance to receive complete resection at diagnosis. And for those who have the chance to have the chance to be resected completely, they have about 5 years survival span, about 40-60%. But mostly, even those who are initially resectable, they mostly receive chemotherapy and also to test tumor biology, to downstage the disease for those who are unresectable at initial time, or to initial unresectable metastasis. So the timing question is not just a surgical one, it's part of the whole treatment sequence. The core clinical question is not simply simultaneous versus stage surgery, it's how to match the sequence to the right patient, whether it's simultaneous, colorectal first, or in other words, the traditional approach, or the liver first, reverse approach, while minimizing morbidity, avoiding the delay for those in the staged management, and completing our zero resection. So with different strategies, of course, there are strengths and risks. Each strategy has a place, and simultaneous, I'm going to detail much more later, but basically the simultaneous approach are mostly preferred for low combined burden patients, and colorectal approach, the traditional approach, for symptomatic primaries, and the reverse approach for the liver dominant disease. The risks is choosing the right strategy for the wrong patient. So if you look back at the history, we will see that the traditional approach was the default strategy. But after 2006, when liver first approach was first introduced, the literature and the clinical debate around sequencing increased substantially. The important point now is that not that one strategy replaced another, but rather than that, the field moved from a fixed sequence to individualized multidisciplinary team-based sequencing. So patient selection is important for sure. It's a real determinant in those patients. It can be basically simplified into liver burden versus colorectal risk. As I've stated, the simultaneous approach fits the low burden, low risk patients, and the liver first approach fits liver dominant disease. And a colorectal first approach fits symptomatic primary patients. But for many cancers, and this entity as well, the resectability is also biological. And even those with controllable extrahepatic disease or minimal progression during chemotherapy may still allow curative intent resection. In this assessment of those patients, as you may all know, the radiological assessment is very important and mostly preferred as a baseline scanning, as an MRI scan, and response assessment is critical because the baseline MRI assessment scan before and after chemotherapy is very important, and especially for small lesions as well. So we must always preserve the surgical map, especially for those before chemotherapy. I would like to state in one slide about this chemotherapy response. It's a timing tool, actually, not just a waiting room. Biology matters as much as anatomy. And in liver dominant or borderline disease, systemic therapy tests the biology of the tumor, the aggressiveness of the tumor as well. As I stated before, it may convert the unresectable disease to resectable status and guides our timing. And it's very important in those patients that the response should not just be evaluated based on the radiological assessments, especially for those with small lesions, like smaller than 2 centimeters and receiving chemotherapy. So in clinical practice, we actually need to more rely on the morphological changes of those patients, not just by the RICE's criteria, as we know, just radiological assessment. Also, of course, the chemotherapy comes along with some risks. Too many cycles in those patients may lead to liver injuries, such as particularly steatohepatitis, sinusoidal obstruction syndrome. Also, another topic, another discussion of the topic, the disappearing liver metastasis. So the baseline surgical map must be preserved. There are lots of studies in this topic. I'm trying to give some of the leading examples. There are not much randomized trials about this colorectal liver metastasis, synchronous colorectal liver metastasis, due to the nature of the disease. this randomized control trial is one of the leading trials. This MetaThink trial, they compared the simultaneous resection with delayed colorectal, the traditional approach in initially resectable patients, and they have seen that at the end of the analysis, the patients had similar morbidity rates, and when they have looked at the 2-year overall survival rates, even though not significant, but they have seen a favored and survival outcome in those with simultaneous resection. In this analysis, it must be noted, which is very important, that 8 patients in the delayed approach could not reach the second stage. So the results of this analysis should be interpreted with caution that simultaneous resection is an acceptable option, but in carefully selected patients, resectable patients. So there are lots of meta-analyses, but most of them, they show no clear survival advantage for either sequence. But simultaneous, as we know, when we look at the literature, we see that the simultaneous approach reduces the length of stay. Because of the selection bias, as I've said previously, this should be interpreted as efficiency in selected patients, not as superiority at all. This updated pooled data support the same message. Similar complications, mostly similar complications and survival outcomes, and as you may see, shorter length of stay after simultaneous resection. This suggests again the efficiency in the selected patients. It shouldn't be interpreted as like one size fits all advantage. This is another one of the leading randomized trials, the COSMIC trial. In this prospective trial, they have analyzed the completed pathways. In this analysis, they've analyzed the 4 different pathways: the reverse approach, the reverse approach, the simultaneous approach, the traditional approach, and in one group there was no surgically resected patients just by chemotherapy. And at the end of the analysis, they have found for either of them, they have found a similar complication rates, similar survival outcomes, quality of life, and length of stay. But the important part in the study is that the failure to complete the treatment, it remained a major issue in this regard because of progression. So the practical question is not only simultaneous versus stage, but it is selected the pathway the patient can safely complete. I think it's not passing to the other slides. Okay. So simultaneous surgery, as I've stated, is increasingly being used, and it is also directly proportional with the gaining experience of the institutions with high volumes. But it's increasingly used, particularly for those with minor hepatectomy, and adjusted survival appears to be comparable across strategies. The key safety boundary is complexity. It should be kept in mind when you're dealing with simultaneous, when you're planning to make simultaneous surgery. So the key boundary is the complexity, because combining the high colorectal risk surgery, those with high risk anastomosis, high risk of anastomosis leakage, I'm trying to mention, with major hepatectomy, major resections, or if there is any doubt about the future liver transplant, because as you all know, those patients are receiving long cycles of chemotherapies, it increases the risk as well. The general risks sharply rises. So simultaneous double major surgery should be avoided in those patients. So since so far, what is the consistent message? What does this literature tell us? The consistent message is this: in selected patients, simultaneous surgery provides similar survival and may reduce resource use. However, safety depends on selection, because risk rises when major hepatectomy is combined with complex pelvic surgery or colorectal surgery. So the evidence supports patient-tailored sequencing, not one universal strategy. If I need to summarize all my remarks about the simultaneous approach, who is the right patient for the simultaneous approach? The simultaneous resection is attractive when it simplifies the treatment without adding risk. A fit patient, asymptomatic primary like obstruction, perforation, which may lead to sepsis, or if there is bleeding that cannot be controlled by means of conservative approach, limited liver surgery, that's important, and expected, which is always our main rule, achieving complete resection at both sides. When it becomes major plus complex colorectal or pelvic surgery, the risks outweigh the benefit. What about the liver first approach? I would like to tell also 1 and 2 slides about the liver first approach. The liver first or the reverse approach, it was first introduced by Menta et al. In 2006. It is relevant when the liver drives the prognosis. Actually, it's not a very correct sentence because the liver prognosis in all these colorectal liver metastasis patients, what I mean here is the tumor volume, the tumor mass when it's confined to the liver. So in this liver met survey analysis, they have analyzed 7,360 patients, and in this analysis, they have seen that also throughout the years, the synchronous approach, its use increased over time. In multiple unilobar and bullobar colorectal liver metastasis, they have achieved better trial survival outcomes compared to the other approaches. So, yeah, when the patients are carefully selected, this is a valid approach, a valid strategy for liver dominant disease, not for every synchronous patient. I have chosen this consensus. It is the leading author, as you may all know, is one of the pioneers in this diagnosis, in this disease. The Professor Ben Adam is very helpful because it turns the timing question into 4 clinical scenarios. If the primary, according to this consensus, if the primary is asymptomatic, whether the liver metastasis or resectable or unresectable, the preferred approach should be first to start to initiate with the chemotherapy and reassessment, followed by surgery if the liver disease becomes or remains resectable. If the primary is asymptomatic, as I stated previous slides before, like obstruction, bleeding, or perforation, then the priority should shift to the traditional primary approach, and then chemotherapy and the liver surgery, so on. So the important part of this study is that the sequence follows not just the symptoms, but also the liver resectability. And the most important part of this management is the multidisciplinary team reassessment. And also, if I need to summarize my remarks about this stage approaches, stage approaches are safer when one side dominates the risk or dominates the other. Colorectal first approach for life-threatening primary symptoms, and liver first for liver dominant or billobar disease. The main problem, the main trade-off in this staged approach is the interval progression. The key endpoint is completing the full curative pathway safely. To conclude my presentation, I want to summarize my remarks. There is no universal sequence, there is no universal approach, no universal standard approach. The simultaneous resection is efficient and safe in selected low-risk patients, but the staged or stage approaches generally are safer when the rectal disease, billobar disease, or the major surgery dominates the risk. Systemic therapy is an important part of this treatment modality, not just surgery. It's not only adjuvant treatment, but it helps to test the biology of the tumor. The response of the tumor to the treatments also is an indicator of the process, in the future process. It can also convert unresectable disease to the resectable status and guides timing. Ultimately, the best sequence is the one that the patient can safely complete. Also, multidisciplinary treatment, multidisciplinary team, the selection is a treatment because in the management of those patients, there's not only us, not only surgeons, even there should be a hepatobiliary surgeon, there should be a colorectal surgeon, there should be a experienced radiologist and an oncologist as well, and the decide should be taken all together to provide the best treatment of those patients. Thank you for listening.
Sorular var mı?
Thank you for your work. Maybe you mentioned and I missed it. I'm here. Sorry. Can you explain your approach after chemo? Like the patient received neoadjuvant chemo, synchronous metastasis, first chemo, and then would you go again like a stage approach, or would you follow the same algorithm regarding the fitness of patient and the easeability of the surgery?
Thank you very much. I mean, those patients are always evaluated in our multidisciplinary meetings, of course. And we always approach the patient like patient and patient. And so it depends on the liver burden, the tumor burden in the liver, and if the primary is like symptomatic, or if there are any obstruction symptoms or bleeding. If there is not, mostly we prefer the liver first approach, mostly. Because as I've stated before, the survival of those patients mostly depend on how much you make the liver free from tumor, mostly. So, as I've said, it mostly depends on the status, the symptoms of the patient, the tumor status in the liver. Yeah, that's it.
I was also meaning, because you usually wait like 4 to 6 weeks after chemo for liver.
Yes.
So would you go like, instead of waiting, I would do the colorectal? Is there an approach like that?
Let's say if the patient has received chemotherapy, we usually at least wait for 4 weeks, or if the patient has received like bevacizumab, then we should wait like at least 6 weeks. But we make reassessment with the radiology, and if the liver is resectable, we usually prefer the liver approach first and then the colorectal approach after like 2-3 months.
Sağ olun Recep Bey. Yeni sorular var. Buyurun.
Good afternoon. My name is Mukhtar Ismailov. I am head of the department, medical surgery department, Taşkent Medical University. I would like, first I would like to say great thanks for a good presentation. It's very important. I just would like to ask you about a leak of anastomosis after the simultaneous and a colorectal surgery after the first surgery. I mean, have you observed the anastomosis leak after the operation?
How do you observe the leakage?
Yeah, leakage. I mean, leak of the anastomosis.
No. Okay. If I didn't understand wrong, I understand as this, like, as I stated before, if there is a high risk of anastomosis, because when you do, the reason when we don't prefer to make major liver surgery with the risky anastomosis, because liver is important part of this immunological system, immune system. When you're doing major liver resection, you also risk the anastomosis due to the immune modulation after the surgery. So of course, that's why after major liver surgery, we usually don't prefer, because the risk of anastomosis leakage is much higher. I mean, I don't have the numbers in our clinic, but we usually don't prefer, like, particularly for rectal resection, because I'm just doing the liver part, because in our clinic, the colorectal part is separate from us. I don't deal with the colorectal surgery, but if they are planning to make a rectal resection, I don't prefer to make the liver resection at the same sequence, because I think, and according to the relevant literature, the risk is much higher at the same time.
Başka sorular var mı? Buyurun.
Thank you on your nice presentation of this very important topic. Synchronous metastasis is really interesting topic in HPV surgery. You mentioned 3 different approaches to those patients. I'm wondering, is there a place for the 4th one? I mean, first chemotherapy, after that synchronous one-stage resection, primary and secondary tumor. In my institution, we do majority of cases in this way with no difference in morbidity, mortality, as well as overall survival. And my second question is about the localization of primary tumor. is there any difference in approach, for instance, for low rectal cancer and colonic cancer? Because for the low rectal cancer, we do have some other therapeutic options like chemoradiation. Thank you.
Thank you for your question. I mean, I think your first question was like, you asked one of the trials was in the cosmic trial, the no surgery. They have no surgery, like watch and wait, maybe you have asked. Again, I'm not dealing primarily with the rectal surgery, the colorectal surgery, but for the liver surgery, we mostly prefer because one of the problems after chemotherapy for the small lesions, sometimes they may become like full remission after the chemotherapy. And like after the chemotherapy, you make the radiological reassessment and you can see no other lesions on the liver. But it's very important. As I've said it at the beginning of the presentation, radiological assessment is not always equivalent to the chemotherapy response. So if we don't see any lesion on the MRI scan or the CT scan, it doesn't mean that it's fully recovered from the liver, from the tumor. I'm talking about the liver. So for the liver, we try, even though it's a perfect response after the chemotherapy, we always try to make surgery, or at least maybe by the ablation by the interventional radiology to destroy the lesions before the chemotherapy at least. But for the colorectal surgery, sometimes our colorectal surgeons may prefer not to do any surgery after the chemotherapy if there's perfect complete response.
Let me precise my first question. After chemotherapy, is lesion are resectable, and do you have some small tumor on transversal colon? What would you do? Synchronous resection or liver first approach?
It's always, I think this is also a dynamic process because probably most of you have experience. Sometimes we plan to make simultaneous surgery, transverse colon resection, and let's say if there are small lesions in the liver, sometimes we plan to make simultaneous resection. If everything goes well, because you cannot know always, if everything goes well, if the surgery does not becomes too long, if there is no bleeding, for example, then we can plan to make at the same time. This is always an interactive procedure because we always talk with our colorectal surgeons during the procedure. Because sometimes they make the colorectal surgery first, and they say our resection, our dissection was a bit problematic. The surgery took a bit longer, and sometimes you should evaluate the patient also. You should always ask the anesthesia as well. How's the patient status? If the patient is receiving, let's say, after the colorectal surgery, if the patient is receiving inotropics, and sometimes we don't insist on the liver resection, we can leave it to the second stage.
Thank you. As we see in pancreatic cancer, what do you think about the resectable disease receiving a neoadjuvant chemotherapy first? For example, left-sided liver lesions, 8 lesions in the left side of liver, CA99 is high, and right-sided colon tumor. This is resectable, right-sided tumor, high CA99. CAI. Other side, for example, the other example is only one lesion, again in the left side of the liver, low CAI, and also sigmoid colon tumor. So, what do you think? All resectable disease should go upfront surgery, or still should receive chemotherapy first, even he or she is resectable? The second one is, what do you think about not the first liver, first primary, not simultaneous, but first ileostomy?
Okay.
Really?
Okay. Okay. So I answer the second question or leave?
Thank you.
The ileostomy. You mean the ileostomy or the first one? No. Okay. I answered the ileostomy question. Yes, of course. If there is I mean, I am going to the same thing again. I think there is no, this is right, this is wrong. Sometimes, yeah, you may change your strategy according to the patient. have we done this before? Have we done like just to make inverting ileostomy and leave the patient and the patient receives chemotherapy and after that reevaluation? Yes, we have that. But I mean, I'm just talking according to the general consensus, general recommendation. And all the world is also speaking, I think, about the same, because I don't know who can say that in this patient, I mean, okay, there are some situations, but mostly always you have to evaluate according to that patients, and like there may be some marker is very high. Sometimes then you just say the CA level is so high, maybe the patient is resectable, but just you may say sometimes, okay, let's refer this patient first to oncology, to chemotherapy. Let's see how it's going to happen, because at the end, our main objective at the end, okay, to resect something is good, to make the liver tumor-free is okay, perfect. But at the end, our main objective is to provide the patient the best survival. This is our main objective. We shouldn't forget it as surgeons, because sometimes it can be like the ambition of the surgeon. The person, probably all of us say, sometimes we can say that, okay, I will make this liver free of tumor. Okay, but at the end, what is important? And that's why I have said that is the role of chemotherapy, because I think also to provide our patients the best survival outcomes, I think the chemotherapy helps us to understand the biology of the disease. So again, same thing, I'm repeating myself. I am sorry, but I always decide like patient.
Çok sağ olun Recep Bey. Etraflı malumata göre aktual temaydı. Sağ olun.
Thank you.
Next presentation. Disabling lessons after chemotherapy, clinical dilemmas, Milligan Project, Serbia.
Dear Chairmen, ladies and gentlemen, it is my great pleasure to participate in this meeting, and I'd like to express all my gratitude to the organizing committee to invite me and to visit this distinguished meeting and your beautiful country. I'm coming from Oncology Institute of Vojvodina, Medical Faculty, Novi Sad, Serbia. And I just want to point out some facts about colorectal liver metastasis. Colorectal cancer is the third leading cause of death in the world, and up to 50% of them, those patients will develop liver lesions. Without therapy, 0 patients will survive 5 years. With some kind of systemic therapy, less than 2%, but with surgical resection, more than 50% of patients will survive 5 years, and 30% of them will survive 10 years. What does it mean actually? Metastatic colorectal cancer is potentially curative disease, and surgical resection is precondition to cure those patients. So, and according to current ESMO guidelines, systemic treatment is indicated in some biologically unfavorable tumor for resectable disease, and in case of in which conversion therapy is needed when to the doublet chemotherapy biologic regimen should be added. Let's go at the very beginning of the introduction neoadjuvant chemotherapy. In 2004, Peter Allen published their work about neoadjuvant treatment for colorectal liver metastasis, and he divided patients in 3 groups who had progression on therapy, stabilization, and partial response. As you can see here, patients who responded to chemotherapy had better results after surgical resection. And it is really good to select patients according to the tumor biology, as it is mentioned in previous presentation. But at the same time, actually the same year, some authors noticed that some lesions could disappear on systemic treatment. So Dominique Elias published this paper in 2004, and he analyzed the 15 patients with disappearing liver lesions. They followed those patients for 3 months, and if there is no appearance of the lesions on surgery, they found 4 patients, 27%, which had macroscopic disease, and they excluded those patients for further analysis. So 11 patients, they actually deemed as a missing liver lesions. In their analysis, as you can see, the follow-up, median follow-up was 31 months, and 6 of them, 6 of 11, 54.5% had viable tumor cells. And authors concluded that definitive cure is about 70%. But in the opposite to this finding, Stéphane Benoit published another paper with 38 patients and 66 disappearing liver lesion in their analysis. Criteria for the DLM was no persistent macroscope or microscope residual disease, or there is no early recurrence in 1 year after the surgery. As you can see here, during the surgery, they found 20 metastases as on microscopic level. They resected 15 initial metastases, and 12 of them had 12 of them had viable tumor cells on postoperative histopathology, and 31 sites left behind, and 23 of them developed metastasis in the first year. So author concluded that only 17% could be cured of those patients, but the disease was present in 83%. So reasons for disappearing liver lesion are multifactorial, but only 2 factors. Neoadjuvant treatment and quality of imaging are under our control. So now accepted definition for disappearing liver lesion was established in 2022 in Saragossa, that the DLM as any lesion presented at baseline contrast MRI, which no longer will be visible on hepatobiliary contrast MRI after systemic treatment. What is very important, that the hepatobiliary contrast based on gadolinium is required to establish diagnosis of DLM. And I'd like to point out that scar on the place where anastomosis was should not be assigned as a DLM. Frequency of this is about 7 to 48%. It depends on different techniques for imaging evaluation of the liver after chemotherapy. Depends of regimens, chemotherapeutic regimens, the duration and number of systemic cycles, heterogeneity of patient, and of course of tumor biology. Which one tool is the best one for diagnosis of disappearing liver lesions? I'm going to show you this meta-analysis published by Madi in 2023. They analyzed 13 series with 334 patients with DLM. The primary endpoint of the analysis was negative predictive value. And as you can see, 0.79 had contrast-enhanced intraoperative ultrasound, but 0.73 for MRI, actually. It means that these 2 tools are the best options for evaluating DLM. Last year has been published DREAM trial. It was a prospective international study with patients with initially unresectable disease, and after that convert to resection. And this trial was conducted in 21 centers in France, Austria, Belgium, United States, and Japan. And finally, 112 patients were enrolled in this analysis. Minimum follow-up was 2 years. And primary endpoint was also negative predictive value for MRI and CT. Secondary was disease-free survival and overall survival. They concluded that the negative predictive value for all patients was only 62.5, which is lower than pre-specified threshold. For CT was 22.9, and there were no significant difference between resected group and left behind group. What is the risk factor for disappearing liver lesions? First of all, smaller lesions, 1 or 2 centimeters, more than 3 metastases, synchronous disease, longer duration of chemotherapy, intra-arterial chemotherapy, oxaliplatin-based regimen, and APC mutation as well. What should we do with the patient with disappearing liver lesion? Actually, we always should keep in mind that disappearing liver lesions does not mean complete pathological response. Actually, it brings us to the situation that we should make balance in a very aggressive approach and potentially complete pathological response. So, what should we do? We should treat those patients or just watch and wait. We can use surgery, ablation, and stereotactic beam radiation. It's very interesting because for this lecture, I didn't find any paper who analyzed stereotactic radiotherapy on disappearing liver lesion. But in my opinion, it looks quite logical to use these therapeutic modalities. But I think that in the future, we will see some results about Suburto on DLM. Watch and wait means carefully follow up and our early reaction. And the key point in treatment of disappearing liver lesion for surgeons is to resect or not such a lesion. I'm going to show you this systemic review published last year by Papa Constantinou. And as you can see in this systemic review, they included 10 series, 326 patients with 1,134 DLMs. 480 were identified and removed surgically. Of those 347 had viable tumor cells in postoperative histology. It means 72.3%. 145 tumors that could not be identified intraoperatively were removed based on previous imaging. And only 30, I mean 20.7% of them presented viable tumor cell on definitive pathology findings. 465 lesions could not be identified and were left in place, and only 155, it means 32.7% of them developed local recurrence within 5 years of follow-up. And authors concluded that recurrence of colorectal liver metastasis was lower in patients who had resection or ablation of group. Authors concluded that resection of the site of disappearing lesion should be considered, and it may offer better survival chances. It's very interesting because they concluded that may affect survival benefit, but they didn't do any survival analysis in their work. So they conclude something without analysis. Okay, it's very interesting. And there are no standard guidelines for those patients. There, of course, future research is required for those patients. But I'd like why I said that they do not analyze any specific data regarding survival. It is well known that there is a higher rate of intrahepatic recurrence in those patients who didn't have any treatment. But it is very interesting that that this difference do not affect overall survival. It was the same in both groups. Nassar performed one systematic review with inclusion criteriums about the disappearing liver lesion and overall survival. And it is very interesting. They author find only 2 papers published with these criteria. And as you can see, no one of them didn't show any surveillance benefit, I mean, with disease-free survival and overall survival. And I'm going to show you also results from the previously mentioned the DREAM trial. They also didn't find any difference, any significant difference in the disease-free survival and overall survival as well, actually. The key point is to know are viable tumor cells still present in the liver and in the body? Maybe liquid biopsy would be helpful for us. Why? I'm going to show you just Japanese observational study, Galaxy, on 3,000 patients. And as you can see, the presence of circulating tumor cells was the stronger predictor of survival. But there is no still trials who analyze disappearing liver lesions and circulating tumor cells. There is only one ongoing trial, DISCOR-MET, and we expect the result for this trial. Okay, and what is our daily practice? I'm going to show you results from this international survey among surgeons, and 226 surgeons respond on this survey, and 63 of them have waited for a few months before the definite decision what to do with this disappearing liver lesions. Only 24 place fiducial markers in lesion less than 1 centimeter prior to neoadjuvant chemotherapy. 49 elected for observation and 31 resect if disappearing lesions was superficial. 87 believe that there is effective treatment with progression on surveillance imaging. So the similar, I'm going to propose, I'm going to show you this algorithm created by Ansari when they suggested if during the operative exploration, if DLM still exists and his removal is not fatty, they suggested surveillance. If it's not detected, also surveillance or possible resection if it's located superficially. If DLM is detected intraoperatively and safe to resect or ablate, then to resect and ablate. So let me conclude. Contrast-enhanced intraoperative ultrasound and MRI are the preferable imaging modalities. Treatment of, we could treat those patients or to perform watch and wait strategy. Okay, watch and wait strategy does have higher rate of local recurrence, but no evidence in overall survival is at the moment. Individual approach and personalized approach to every patient should be performed, and further research is necessary in this field. Thank you for your attention.
Thank you. No question? No question. Okay.
Thank you for this nice lecture. For many surgeons, disappearing colorectal metastases, they are the complication of chemotherapy. Yeah, we should consider like that.
Yes.
After the 8th cycle, it should be very cautiously decided on tumor boards, multidisciplinary tumor boards, to my opinion. This is also the idea of Rene Adam of this group also. That's why we should be very careful as surgeons to make a close cooperation with the medical oncology. Many patients are receiving chemotherapy, and if they are happy, the medical oncologists, they are moving on, and the metastases, they are disappearing with some vital cells, and they are recurring. But in the meantime, the liver becomes bad because of the chemotherapy. The parenchyma quality is getting less, and that's why I think the key point here is the close cooperation with medical oncology, not to leave the patients completely to the medical oncology, or to decide after the 4th or the 8th cycle if we resect it, because these metastases, they are becoming smaller, especially the small ones on the periphery, and the risk for the disappear is quite high. That's why I would like to suggest for us all, the surgeons especially, to work closely with the medical oncologists. It's becoming a bigger problem nowadays.
Yes, thank you. This question, because of time, I hide slides about the importance of a multidisciplinary team. Actually, medical oncologists and radiologists as well. That's, I agree with you that happy oncologists sometimes means sad surgeons actually, and we should cooperate really and very closely for such a patient with potential risk of disappearing liver lesions.
Let me add something, as small thing. Furthermore, it's also important that the patient is assessed from a liver surgeon. Not all the general surgeons are liver surgeons. They are quite happy when the metastases are disappearing. It's also a problem for the medical oncologists also. They do not cooperate all the time with liver surgeons. And some surgeons are also suggesting, okay, moving on with the chemotherapy, and afterwards, when it recurs, then a real liver surgeon sees the patient with a really bad liver parenchyma. That's another point in most centers.
That's very important. Who estimate which lesions are resectable or not? There are many papers on this topic. I can't forget one when collect all. It was 62 patients in one academic center who were sent on palliative chemotherapy, and their MRI and images sent to 6 famous hepatic surgeons in the world to reanalyze. And it is very interesting that 63% of them, according to majority of surgeons, were assigned as a resectable or potentially resectable disease. So it could be a very interesting topic about our differences. All of them looks at the same picture, but with different knowledge, with different approach. So MRI picture is objective picture, but our interpretation is extremely subjective. But patients, outcome of patient disease depends of our subjectiveness at the end.
Thank you very much. Thank you. This end of your presentation. I want to invite our next speaker, Danko Mikuluc from Croatia. Yes, floor is yours. Okay.
Okay, thank you. Okay, so thank you very much for the invitation. Also, thank you for the hospitality in Taşkent. We've been really enjoying the last 2 days. So the topic is continuation on colorectal liver metastasis. However, in a much smaller group of patients and very selected group of patients who might undergo liver transplantation for colorectal mets. Just a brief note on where I come from. It's Croatia. It's a small Central East European country. We are about 4 million population in Croatia with a decent cadaveric organ donation rate. So we are able to manage our liver failure population fairly well. Over the last 28 years at my center, we've performed a large number of liver transplants, however, almost exclusively cadaveric, and only in a very small number of patients we've done liver transplantation for colorectal mets. So our experience, of course, is limited, and also to note, those cases were done a long time ago when we didn't have the selection criteria and all the knowledge that we have today. So it's a long story. It started with Starzl, who actually the first cases he performed were almost exclusively done for liver malignancies, either primary or secondary. So in the early phase of liver transplantation, it was a very hot indication, of course, an ideal way to solve the malignant disease in the liver, the most radical surgical therapy. However, once the results were analyzed in the 1990s, it was realized that the outcomes were pretty poor. So then the number of indications for malignant disease in liver transplantation dropped to maybe 10%, and it remained low until we finally found out what the importance of selection criteria. First, of course, with the HCC, then the pericyclic cholangio, Milan criteria for neuroendocrine metastases. And once we knew the importance of patient selection, then again the idea of liver transplantation for colorectal mets reappeared. Of course, we also needed more grafts. We had to deal with the scarcity of livers for transplantation. So with the broader use of extended criteria donors, DCD donors, living donors in the Eastern world, again the idea of transplant oncology was appeared again. As for CRC, unresectable CRC metastases, again back to the early 90s, survival was dismal and the concept was abandoned. Then in the 2000s, there were sporadic cases. We published a couple of cases at our center. However, also those cases came before selection criteria, and actually we were very lucky to achieve long-term survival and even cure in one case of living donor liver transplantation for unresectable colorectal metastases. Then after 2010 and the Norwegian data, the idea became popular again, and prospective studies started in France, in Germany, in Canada, in the US, in Belgium, and finally what we have now, we have the results of the TransMed study published 2 years ago, which appears to change the landscape. The Norwegians started in 2000, somewhere before 2010, with almost no selection criteria. You can see down there they only required complete excision of the primary, good performance status, minimum of 6 weeks of chemotherapy, and absence of extrahepatic disease. So that was all they had in the beginning. However, they did manage to achieve 5-year survival of 60%. However, with a very high rate of recurrence, both in the liver and in the lung. However, that was the start. They did manage to learn what of some of prognostic factors like the low CEA, the size of the largest lesion, the time spent between the primary surgery and the liver transplantation, and finally the importance of either having no progression on chemotherapy or desirably regression of disease on chemotherapy. Then a couple of years later, they published their extended experience with liver transplantation for unresectable colorectal metastases. Again, a single-arm prospective studies. However, they did use somewhat more strict entry criteria, like no disease progression on chemo, low CEA, minimum some response, at least some response to chemotherapy in terms of size of the lesions, and more than 1 year from the diagnosis, and actually very good overall survival rate of more than 80%. Finally, coming to the most recent study, the first randomized control controlled trial led by René Adam. It was a multicentric study done in France, Belgium, and Italy, initially comprising 94 patients with the intention to treat, and then getting about, I think, 76 patients into the protocol. And once they analyzed the data of the patients who actually entered the protocol and were either transplanted or left to palliative chemotherapy, they managed to get 73% overall survival in the patients who underwent liver transplantation, which is in big contrast to the patients that were left to chemotherapy only. So how did we get here? Of course, we had much more expertise in transplantation than we had 20, 30 years ago. We know much more about the biology of colorectal cancer. We have better chemotherapy. We have better imaging. We have immunosuppression that, in addition to immunosuppressive properties, has anti-tumor properties like the mTOR inhibitors. However, we all agree that patient selection is the king or the queen, or however you want to name it, but that the patient selection is crucial. So these are the differences in patient selection between the early trials, between the Norwegian trials and the Transmed trial and the French trial. So now all the patients with BRAF mutation are excluded as they show aggressive behavior. Then another important element is the inclusion of an independent committee who reviews all the images, all the clinical data. It was mentioned also in the previous talk in the discussion, the importance of not only multidisciplinary, but also multiple surgeons or multiple radiologists looking at the images, and independent committees doing that. Also, the importance of the number of lines of chemotherapy. The patients who underwent multiple lines of chemotherapy are often not good candidates for this kind of treatment. And again, the value of low markers, stability on chemotherapy, regression of disease on imaging, etc. Also, another new concept is that we don't always try to achieve cure in this setting, that we try to achieve something from that can be considered palliation. However, this is not palliation like best supportive care. It's palliation in terms of prolonging the patient's life for 3 years, 5 years, maybe in the setting of recurrent disease. However, 3 years or 5 years is a lot of time when we compare it with the best oncological treatment that may achieve prolonged survival of 3 months or 6 months. Then 5 years or 6 years is really a long time span. So most of the patients do recur. In the transplant study, at 5 years, 80% of the patients recur. However, 70% of the patients that were transplanted are actually alive. Most of the recurrences are in the lung. They are reported to be treated pretty well, either with lung surgery or with ablation. So in a large number of patients, actually secondary remission is achieved. So we even might get cured, might get overall cure in this group of patients. Again, coming back to patterns of recurrence, most of the patients recur in the lungs. If they recur in the liver, then the prognosis is much worse. And most of the patients with liver recurrences will have systemic recurrences, either lung, bone, and so on. So these patients fare pretty poor. Finally, the access to liver transplantation, of course, it's not the same. It's not the same in France. It's not the same in Norway. In Norway, when they started the SECA trials in around 2010, they had very good donation rates, very low patient mortality rates on the waiting list, so they were somehow able to afford to go into this new field and actually find the grafts for liver transplantation in colorectal mets patients. In the TransMed study, it was initiated as a clinical study from 2016 to 2021, and in France they managed to afford at least 15 patients a year, and they managed to prioritize those patients. So all the patients waited less than 2 months until liver transplantation. Once they had the transplant data, now it's an accepted indication, of course, with all the selection criteria respected that we mentioned before. It's an accepted indication for liver transplantation in France. However, with somewhat less priority, they all get transplanted between, I think, 4 to 6 months. Finally, the very important factor that Adam emphasizes is the evaluation of eligibility by an independent multi-institutional board. So this way they avoid all the compassionate indications, emotions, empathy that we all tend to show towards our patient when it's our own patients. We look at the age, we look at the family, we look at how long we have been treating them. So we may be subjective in indicating the procedure itself. These are the IHPBA guidelines. We also have the IHPBA guidelines, which do not differ much from the TransMed guidelines. So it's good to know that the IHPBA also has guidelines regarding liver transplantation for unresectable colorectal mets. And finally, what does the future bring? Probably better selection via circulating tumor DNA and more tools to evaluate the biology of the tumor, like molecular profiling, next generation sequencing, taking into account the metabolic tumor volume, right colon primaries. Female sex have been shown to be poor prognostic factors, so it's probably more selection is required in those patients. Finally, the timing of liver transplantation, how long can we wait, how fast and how quickly should we prioritize the patients to not to wait too long. On the other hand, not to hurt other patients on the list by prioritizing the colorectal mets patients. How many lines of chemotherapy are too much, and so after how many lines of chemotherapy should we still attempt to transplant and hope for a good outcome? Now, among surgeons and transplant programs who are very, very eager and very enthusiastic about liver transplantation for unresectable colorectal mets, there are even ideas about transplanting borderline resectable disease, which I don't think is realistic at this time. And finally, the key, of course, both in the East and in the West, is the expansion of the donor pool, either by marginal donors, DCD donors, or in the East. I think now with the results of the TransMed study, you also have the sound evidence and the ethical base to go into liver transplantation with living donation for unresectable colorectal mets. So that's it. Thank you.
Thank you very much for your exam. We can get only one question before the case discussion session. Do you have any question or comment? Yes.
Thank you, Professor Mikulic, for this nice presentation. I would like to ask you, do you have formal criteria in your center that you keep, or you decide for each patient individually before the transplantation? And the second one, for these two cases, what is your observation after the transplantation? Do you observe the recurrence?
Well, at our let's start with the cadaveric donation. At this moment, let's say in Croatia, we have such large, still considerable rates of waitlist mortality that we cannot do cadaveric liver transplantation for colorectal mets. The ones we've done in the past were living donors. And at the time we didn't have the Transmet criteria or the Oslo criteria, so the ones we did, we only required them to have no extrahepatic disease, and that was basically all we knew at the time. So these were the only criteria, and we had some. Of course, we wanted to have a period of, I think it was at least a year from the resection of the primary until the liver transplant. In the future, we'll see. Once we increase the cadaveric donor rates, we might go into cadaveric transplantation again. But for now, I think we are left to living donors, and for those also, I think it is sensible to use the Transmet criteria or the Oslo criteria, which seem to provide the best outcomes.
Thank you very much.
Okay.
Thank you. Yeah, okay. Thank you very much for your nice presentation. I want to invite Professor Ağlar for his presentation or cases.
Dear chairmen, dear colleagues, I'm very happy to be here with you. After a long day, I know everyone is a little bit tired, but please do not hesitate to speak about your suggestions and ask something about cases. Today, we present 4 cases with radiologist Dr. Gonca Elden from Hacettepe University, Ankara, Turkey. I have no conflict of interest. All cases are from our department, 9 Eylül Üniversitesi, İzmir. Our first case is 46-year-old woman. A sigmoid colon tumor was detected during evaluation for abdominal pain and anemia, and biopsy confirmed adenocarcinoma. At the same time, imaging showed us a synchronous metastatic tumor in the left lobe, measuring approximately 4 centimeters in diameter. The serum CA level was markedly elevated, 315 nanograms per milliliter. The case looks like a synchronous metastasis colorectal cancer. There is a short video of her CT. We see the tumor in the left lobe. The sigmoid tumor is very small, so there is no obstructive lesions. At this time, is there any suggestion? MRI is an important thing for finding some new lesions. MRI is what was doing for this patient and showing no extra lesions. There is only 1 lesions. PET-CT, we don't make PET-CT for these patients. We find thoracoabdominal CT is enough and MRI, but it can be done. You suggest synchronous resection, but maybe we can point that serum carcinoembryogenic antigen level is a little bit high, about 300. Please.
Synchronous disease, especially in this case, this high CEA means the bad tumor biology.
Yeah.
And according to consensus conference in 2022, all synchronous disease are tumor with bad tumor biology, and chemotherapy should be the first, especially if primary tumor is not symptomatic.
Yeah, that's right. We are totally agree with Dr. Sorry, I forget your name. So, Dr. Pratic, this is a cornerstone article. This is old article, but cornerstone article from Human Fong et al. They are strongly proposed that high serum CA levels is important prognostic factor for recurrence. Also, update ESMO guidelines recommended neoadjuvant chemotherapy for patients with unclear prognostic situation. Because the primary tumor did not require emergency surgery, we started this patient with systemic therapy. After chemotherapy, the radiologic disease is stable, but serum CA levels are decreased. What should we do now? We have, but the same. So for the correctness for the time, I didn't add the imaging. The same. What about the primary?
I would be recorded at the same time. Synchronous resection, maybe, yeah. Would be.
Dr. Pratic? Synchronous resection. You prefer minimally invasive or open surgery? Minimally invasive surgery is the good option. We performed minimally invasive surgery for this patient. There's this very short 2 minutes video. We prefer synchronous resection and started with liver. First, we performed Pringle maneuver. Pringle maneuver can also be used extracorporeally or intracorporeally. We performed extracorporeal Pringle maneuver and intraperoperative ultrasonography was mostly done in these cases. We use cavitronic ultrasonic surgical aspirator CUSA for this case. It helps for good parenchyma dissection. And there is a good option for working to a surgeon with who knows liver anatomy and liver surgery. We use sometimes clips and sometimes endostapler. This is a segment 2 and 3 pedicule. We prepare the pedicule and we use endostapler for clipping and cutting. Appropriate preparation with working on preoperative radiologic image is important. There is a large vessel, the large vein, who directly flows to the middle hepatic vein. In this case, we found this vein and preparing this vein. And we use also endostapler, but it could be used with another device. This is an option. And we finished this case. After finished our operation, colorectal surgeons of our department continues this case. Pathology is proved metastatic disease, and the patient received adjuvant chemotherapy and follow with uneventfully for 4 years. If there is any, yes, left lobectomy, not left hepatectomy, segment 2 and 3 resection. Yes, left lateral section. Okay.
Sorry, I have a question.
Please.
Have you always used Pringle maneuver for left lateral section?
We don't use.
I never use.
We prepare the Pringle maneuvers, but in this case, about 2 and 3 minutes, very small use. But every laparoscopic liver surgery, we prepare the Pringle maneuver first, if needed.
Me too, but especially for the left lateral, I never use Pringle because when you control segment through into branches, there's no bleeding.
But some patients, maybe some central venous pressure maybe become high during the operation, and some venous bleeding is become higher and higher, and sometimes we use it, but not routinely.
Okay, thank you.
Can I add a discussion? Gian, it's me. Okay. Who is doing your intraoperative ultrasound in general?
Our radiology team comes to operation room, and we prepared the laparoscopic ultrasound device approximately 15 minutes ago, and they come and they do the intraoperative ultrasound. Then we make a photograph all together, and they go. We continue with our second case. This was a 56-year-old woman presented with fever and right upper quadrant pain. She had a previous history of anterior resection for sigmoid colon cancer in 2015. The pathology had been moderately differentiated adenocarcinoma, T3 and 0, and she had not received adjuvant chemo or radiotherapy. During the last 6 months, she had presented to the emergency department 3 times with remorse and fever, which suggesting recurrent cholangitis. This is the laboratory findings. This supported an inflammatory and cholestatic process. White blood cell count was elevated, CRP was high, and liver enzymes showed a clear cholestatic pattern with markedly elevated GGT and alkaline phosphatase. Total and direct bilirubin were also elevated. These findings were compatible with biliary obstruction complicated by infection. There is a MR. Gonca, can you show us the MRI, please?
Can you switch to my screen, please? Okay, so a little bit of radiology. When I first look at the MRI images, the first thing I check is the T2 weighted images. So this is like a simple CT for me. What I do is I delineate the borders of the organs. I take a great look, a general look at the images. The first thing I see is that there is the hyperintensity in the left lobe. And as you can see, the left lobe is atrophied with a hypertrophied right lobe. Looking back again with the T2 images, you can also check it with the fat set T2 images. This is the fat set. That was the normal T2. Fat set means we suppress the fat around the subcutaneous tissue. Here you can see this is the main bile duct. Here we see a nodular lesion measuring around 1.5 centimeters. And proximal to the lesion, the bile ducts are atrophied, and the reason of the atrophy of the left lobe is probably an obstructing lesion. So first things, when you see this, when we see an atrophied or a retracted liver segment, 3 things come to our minds without even looking at another sequences. It can be a cholangio, it can be a atrophied liver, atrophied segment, or breast carcinoma metastases do these retractions. Moving along, because the history gave us a history of colon cancer, but she's still a female. I want to look at the contrast enhanced images, so I'm closing these up. Here you can see this is the arterial, portal venous, and moving on. They have taken a 20-minute phase and a late 40-minute phase imaging. So let's look at that. This is the lesion. It's here in the arterial phase. It's not a perfect arterial phase. It's kind of a portal arterial phase. It's not really enhancing. Okay. Maybe some subtle rim enhancement around it. If I'm going fast, please slow me down. And in the late phase imaging, here is the main duct obstructing it. Still no enhancing. If this were a cholangio with the 40-minute images, I would expect a little bit of enhancement because of fibrous tissue. But still, I'm not 100% certain, because there I can see some mild hyperintensity, but this can also be due to cholangitis. One thing you need, if you're not sure, we usually check the division images. I'm going to show you that. Whether it's a benign or a malignant lesion, here you can see the restricted division. This tells us that this is a mass and it's malignant. So this area is not a great place for a biopsy. You can only do it with a colonoscopy, right? Anyone who would disagree with this?
Yes.
So we would say the report will come out like an obstructing lesion atrophying the left lobe of the liver, possible intraductal, most likely intraductal, Klatskin question mark, intraductal metastases question mark, because I have the history of the patient.
Thank you.
As colorectal met.
Yes, thank you. Can we go on with my slides, please? Dr. Gonca summarized the MRI, and after that, there is no sign of extrahepatic disease. We need to make a decision. Maybe we can do a cholangioscopy for biopsy. After that, percutaneous biopsy not suitable for this patient, but after the biopsy, chemotherapy may be an option. And the other option, resection with assuming hilar cholangiocarcinoma. Is there any suggestion? There is no suggestion. The Balkan sites proposed resection. What about the other sites?
We are at the same site.
Everywhere, every time.
I will do biopsy. It will be a bit difficult. Maybe we need immunohistopathology. I think both. I think it can be a colorectal metastasis. It can be a colorectal or intrahepatic cholangiocarcinoma, periodic carcinoma. They are both adenocarcinoma, but through immunohistopathology we can find the exact diagnosis, and then we decide on.
You proposed the
biopsy, percutaneous biopsy.
Percutaneous biopsy.
It's a liver tumor.
It can be option, but the biopsy change on our plans for segment 1 resection. If we propose this hilar cholangiocarcinoma, we must do left hepatectomy with
not only this one. There's also another difference for ICC lymph node metastasis paraortal. So, for example, it's an neoadjuvant treatment criteria,
but there's no sign for metastatic lymph nodes for preoperative imaging.
Okay, this is a discussion. You can. This is your opinion.
Is there the cholangitis now?
The patient had a history for 3 times cholangitis, but now there is no sign for cholangitis. She was stable at this time.
What about tumor markers?
Tumor markers, I can see it, but tumor markers are the tumor markers are normal. We planned left hepatectomy extended to segment 1 and extrahepatic bile duct resection, and we do frozen section margin assessment during the operation, and we do separate anterior to the posterior ducts to ductal jejunostomy. This is a perioperative cholangio imaging. We see also like Klatskin tumor. We can't see the left side of bile ducts. And this is a small video of specimen. There is abscess area on the left lobe, and we see the choledocus, and at this we see the right anterior and posterior duct margins, and we see the segment 1 also.
Cihan, may I ask a question? Cihan,
please.
Did you resect extrahepatic bile duct depending on frozen section analysis or At the beginning.
At the beginning, like
Why?
we operated this patient like a hilar cholangiocarcinoma.
Okay. Why did you accept it? Like,
Because it seems like a cholangiocarcinoma, and if it's after the pathology reports, it becomes a cholangiocarcinoma, and we don't resect the extrahepatic bile duct. This is an not proper and true surgical aspect, I think.
but if the frozen surface, cut surface was negative, I mean the confidence point of left duct, so it would be enough.
Sorry?
If the surgical margin was negative, unfrozen section,
yes,
of the left duct, left main duct,
yes,
it would be enough to not resect the extrahepatic bile duct. No necessary to resect the extrahepatic bile duct.
There is a obstruction in both hilar section, so we need to go to right anterior and posterior sides. There is a cholangio image can clearly show us the lesion come.
Okay, but now the no dilatation on the right side, I think. In on MRI. No. Okay, so
and we need to go over there. We need to protect this part.
Can I?
Yes, Dr. Can.
Did you take any CT angio before operation?
Yes.
CT angio?
Yes.
Okay. So
there is no vascular invasion?
That's important because if there's a risk for arterial invasion of the right-sided arterial invasion as well. Would you be willing to do resection directly if you see a suspicious invasion of right hepatic artery?
If there is a invasion of the right hepatic artery, there is a different contagion. Locally advanced hilar cholangiocarcinoma is an option. Maybe at this time we make a cholangioscopy with biopsy and first neoadjuvant therapy, but there is no sign for extended disease to the right side.
Okay, crucial, important in this situation, I believe.
Yes. Thank you for your suggestion and addition. This is the remnant part of the liver, and the pathology revealed us intraductal colorectal cancer metastasis. There is 8 reactive lymph nodes. Our margins were negative, and the findings were immunochemistry was finding non-colorectal carcinoma. In this lesion, this is a mimicking biliary tumor, like Klatskin tumor, but the pathological problem is intraductal metastasis of colorectal cancer. There is a rare condition, but it will be published from some centers with low case numbers. Let's
Ask
go.
you something, please. If there is a cholangio cancer of the main left lobe duct without involvement of biliary tree bifurcation, is it intrahepatic lesion or hilar cancer? I think that it is the key question.
Can I ask again? Sorry for.
If we do have a cholangiocarcinoma which affect, for instance, left lobe,
yes,
without involvement of biliary confluence,
yes,
is it intrahepatic cholangiocarcinoma or hilar cholangiocarcinoma?
Maybe we can check out the MRCP images here. Can you switch to my screen, please? This is the high-weighted T2 division images, MRCP images. So here's the main duct, and this is where the lesion is. We don't see the left lobe, and it's not actually, it's extending into the orifice of the right lobe, right bile duct, but it's not really classical, but it has its borderline extension. But I'm gonna save Cihan. When we check out again the late images, the late phase 40-minute images, you can see there are some delineation in the caudate lobe here. So maybe taking out the caudate was really a smart thing to do. But as his question, you don't see any dilatation in the right lobe bile ducts. But this is definitely you can just trace the bile duct here, and it's an intraductal lesion. We would call it like that.
Thank you. Is there any other questions, or we can move to our third case? Can I take my screen, please? There is a problem on my hand. Okay. Our third case is 57 years old man. In April 2022, he was admitted to chest pain, diagnosed with acute myocardial infarction, and a coronary stent was placed. During follow-up, under antiplatelet therapy, low hemoglobin levels and melena were detected. Thoracoabdominal CT then revealed a colon tumor and synchronosus liver metastasis. He had some comorbidities. When we look at the laboratory tests, they showed us a preserved liver function, no hyperbilirubinemia. CA levels were at 50.6 nanograms per milliliter, and CA cancer antigen 99 was also elevated a little bit. Can we see the thoracoabdominal CT, please?
Switch to my screen, thank you. So the first images on your upper hand, you see the CT. They have taken a non-contrast phase and the venous phase. You don't need this, okay? This is extra radiation. You don't need this. Let's close it, okay? So everybody learns it. If you really want to do another imaging, get an arterial phase. At least you will get the hepatic arterial or any arterial anatomy. So let's start with the beginning. Let me just like that. Okay, right away, we see on the left lobe, segment 2, segment 7, segment 4B, massive hypodense lesions. Also, we have a small one right in the segment 3 margin. Other than that, when you look at the splenic flexura, you see the gross lesion extending into the serosa. We would say this is also invading the stomach with additional lymph nodes and peritoneal extensions, and no periaortic lymph nodes, no other peritonitis, imaging findings of peritonitis, no ascites. So your report will come out as 1, splenic flexural lesion extending into the serosa, invading the stomach. 2, the liver metastases. What would you do?
Thank you. Can we return my slides, please? And I want to say, thank you. There is Dr. Gonca shows us radiologic images. What should we do now? Please. There is no obstruction sign now, and there is no bleeding now. Initial chemotherapy was suggested for Mustafa Kerem. I think everyone suggested the chemotherapy. Is there anything about something say?
We should do colonoscopy to have the biopsy from the tumor and to make a genetic tests. And if we saw the obstruction during the colonoscopy, it's possible to place a temporary stent because during the chemotherapy, often we could have a obstructive disease.
Yes, thank you for your contribution. This is very important. Dr. Elçin.
The abdomen, the thorax also after a good chemotherapy response, I would like to see like the paraortic region as well. because okay, this is CT scan, but I would just a complementary role of PET CT. I would like to see as well before the chemotherapy.
Yes, thank you. Yes,
Yeah.
for defining the exact lesions, you are right. We planned the systemic chemotherapy for this patient because there is no obstruction in both clinic and both colonoscopy. And we start with, we placed biopsy for and finding the adenocarcinoma, evaluate as synchronous metastatic colorectal cancer, and we start with systemic therapy. After 6 cycles of chemotherapy, MRI showed bilobar metastatic lesion. Maybe Gonca will show us.
Can I have the screen back? I'm very demanding, sorry. So this is the, let me close the CT. This is the post-chemo MRI. Immediately, again, I'm checking for T2s. You can see the primary lesion has shrunken, and all the lesions in the liver have also responded to chemo as well. Maybe the one in the segment 4B a little bit less, but still it has reduced in size. So we have going back, if you want to report it again, segment 2 exophytic lesion, a segment 3 subcapsular lesion, a segment 4B gross lesion, the biggest one here. Let me go in 6 centimeters, and the segment 7 lesion at the posterior segment. The primary tumor has shrunken. Still, I would be suspicious about the invasion of the stomach. Let's check some other images for that. But still, again, and the response in the primary lesion as well. No periaortic lymph nodes. No suggestion of peritoneal carcinomatosis. This is the venous face. Here is the primary tumor, again invading the serosa. Yeah.
Thank you. Can we continue with my slides? 5 cycles. Full fox.
And we have no PET, right? After the chemo.
Sorry? I can't remember, sorry. But after this situation, the patient continued and he had comorbidities, especially after myocardial infection. We continue the chemotherapy. We had response to the chemotherapy regimes, so we cannot change it. We continue. After this situation, we make another MRI. Do we have MRI
No,
at?
we have a CT.
We CT.
We have a CT. I think it's the completion chemo. Again, suggestive of the stable findings with the MRI.
Right.
But maybe it's easier for you to understand, like the posterior segment lesion, the segment 4B.
There is no major difference.
The little one on the subcapsular area, segment 2, and the primary tumor still.
So
it's
we
invading.
can't see. Sorry, Gonca, we can't see your screen.
Oh, sorry.
Can we see Dr. Gonca's screen?
Okay, starting back. The lesions in the liver, they're almost the same as the MRI. The posterior segment lesion, segment 2, exophytic, subcapsular, segment 3, segment 4B. And maybe you will, it's better for you. We have the primary tumor, yes, shrunken, but still we can see the fat plane between the stomach and the splenic flexura is gone, and it's still invading here. There are some periportal lymph nodes, like these tiny ones. But if the short axis is not exceeding 1 centimeter, we don't accept them as pathologic. No gross lung metastases at the basis.
Thank you. Can we turn back our slides? My slides. We make a volumetry for these patients at this stage. We measured the volume of the segment 1, 2, and 3, and 4A. Sorry? Total volume liver is about 1,055, I think, but I don't remember. In our sorry? We can't measure in this patient the total volume. It's not need. We only measured the remnant volume because this is not a transplant patient.
It seems that you prepare your patient for the right hepatectomy.
Yes. Right hepatectomy is not enough because there is a big mass on the segment 4B and there is a lesions at segment 2 and 3.
But the principle of surgery of liver metastasis is parenchyma sparing surgery, especially in this case, which had its cirrhotic liver. Why you didn't try to preserve some segments of right lobe, especially 5 and 6?
Yes.
Instance.
Maybe there is a missing on the MRI we get here, but on diffusions, there is small lesions on right side also. There is a bilobar liver metastasis and big primary tumor, a cardiac comorbidity, no sign for ileus. The surgery seems like a good option, but we should do liver first surgery or synchronosis surgery. Can you suggest anything? No.
Gian, I totally agree with my colleague. We can also plan a left hepatectomy with segment 7 resection. This is, for me, at the first sight, it looks feasible. And also, I always look with this so-called surgeon-friendly coronary planes, and I can understand more. I think that this segment 4B metastasis is a little bit exotic.
Yes.
That's why maybe we can just, all of them can be resected with tumor-free margins.
Yes.
It's also possible. And a second thing, I think that this is the best time to operate. Coming back to the lecture of my colleague, after the 8th cycle, there's the time limit. He receives oxaliplatin-based chemotherapy. We should act with liver right now.
Yes.
Synchronous, I will not do it. Maybe if it is possible, you can do stoma. It's my personal preference without anastomosis and some limited resections when it's possible.
Yeah. Is that, please? Okay.
Yes, of course. I'd like to do first liver surgery, and after completion of resection, I will check the patient status and probably continue with the colonic resection, especially because the extensive lymphadenectomy for colon cancer is not necessary because we do have stage 4 of disease.
Okay.
Yeah.
I can see. Sorry, Dr. Can.
No problem. Actually, I would do intraoperative. I would plan for an intraoperative ultrasound as well. Also, microwave ablation, because in this situation, the segment 2 lesion is okay. Segment 4B is okay. I agree with the Kaya. Also, the segment 7 okay. We can do a parenchyma sparing large metastasectomies for those three lesions, but we may have multiple segment 5, segment 6 small metastases there.
Yes.
So
and also segment 8 and segment 7.
So it's big challenge.
Yes.
So we need to be ready for ablation, microwave ablation, and decide according to intraoperative ultrasound, I think.
Yes. We always do intraoperative ultrasound at colorectal cancer liver metastasis case, and we always prepare our interventional radiology team for microwave ablation during the surgery. At this disease, we choose operation for this patient. Liver first approach was chosen in multidisciplinary tumor board. The patient underwent right hepatectomy, extended to segment 4B, combined with segment 2 metastasectomy from left lobe, two metastasectomy from left lobe. This is the remnant liver. It seems just left lobe and segment 1 volume is adequate, but this should be kept in mind. This is not a normal liver, so we need a higher amount of liver volume. So we preserve segment 4A at this time, and this is the resection plan. This is the specimens of our after our operation. Sorry. And pathology confirmed our metastasis. They are metastasis. Surgical emergence were negative. During postoperative follow-up, the patient developed nausea, vomiting, and abdominal distension. Abdominal X-ray showed air fluid levels, and we make a CT on postoperative day about 20. Can we see the postoperative CT?
Can you switch line on screen, please? Thank you. This is the post-op contrast enhanced CTE. Here you can see the resection margins, the loculations in the anastomotic areas. And right away, you can obviously delineate the obstruction in the colonic segments because of the primary tumor obstructing the bowel. No fluids. This is the venous vein, sorry. So the primary tumor has obstructed the colonic segments, and the obstruction is due to the primary tumor. The anastomotic sites look fine, but this is an early post-op CT. Just remember that. No residual tumor in CT limits. So I think you need another surgery. Oh.
Okay, thank you. Can we turn up my slides? Let's look this point now. I'm sorry about putting a stoma during the first operation. There's a primary tumor complication. What should we do now?
It is easy to be general after the battle, but when we see the size and the position of the tumor at the start of the treating of these patients, it can be supposed that in some time we will have this situation. So maybe I will start with at least the resection of the primary tumor, because we can expect that in some part of the treatment of these patients we will have this situation. So
yes, you are right, but at the beginning the patient had very new coronary problems, and it's not suitable for surgery. And during the chemotherapy course, there is no sign for ileus. So, and the primary liver is chosen for the best oncological results.
I understand, but from my experience, the cardiac patients very often have the more problem from the anemia of the when they have losing the blood from the tumor. They are usually on this Pigrel Eliquis or this kind of the drugs. So how to say, they lose more blood on the primary side. So for sure, I will start with the bowel resection.
Please, doctor.
I'm sure that it is impossible to put a stent.
Yes. There's options, stoma bypass stent.
Cihan, Sorry, after you, I will ask you a question. Okay.
Okay. Emergency primary tumor resection is another option. En bloc gastric resection because the primary tumor invades the gastric part of some gastric parts. And another question, protective ileostomy is required for this patient. Please, Dr. Ahmet.
What do you think about doing primary and left-sided liver resection or clearance from the tumor of the left side of the liver? Then in a second operation, do only segment 7 resection.
There is a lot of small metastasis in right side.
A lot of
small metastasis in
which segment?
Segments, both right liver, and intraoperative ultrasound may reveal this, can reveal this in this patient.
I think a take-home message will be for this patient. If you are planning or if you need to perform a major liver resection, like here, extended right resection, each complication increases the risk of liver insufficiency afterwards. It affects the liver regeneration, such as ileus infection and so forth. That's why I will do. There was a risk from the beginning in this patient of ileus, and I would do at least a colostomy for these patients in order to reduce the risk of liver insufficiency
after the first surgery, right?
During the first
surgery.
The first surgery. Otherwise, we are taking this risk of liver insufficiency, post-op liver failure.
This is the reason why I presented this case.
I didn't know that. But most of the case discussions, it ends with happy end. That's why I'm still optimistic.
It will be answered at the end.
Do we have a gastroscopy? How big is contact and infiltration of stomach?
There's a small invasion to the.
Okay, it could be only resection of gastric wall. Gastric resection is not necessary. Partial, yes.
Partial gastrectomy is enough for patients.
Okay.
And we decided to emergency en bloc subtotal colectomy with partial gastric resection, and we make ileosigmoid anastomosis. But the patient's general condition, we need a protective ileostomy. The pathology was well-generated adenocarcinoma. There is T4 and N0. After this, patients received adjuvant chemotherapy, and oncologists prefer to follow up this patient with using PET-CT. There is no evidence of recurrence. This is the newest CT image about 2 months ago. There is no sign for recurrence. We see the newest image. And this is the newest PET-CT image. There is no sign for recurrence also. The patient is good now. But I'm totally agree with Dr. Kaya. First, open stoma is a good option for this patient. Thank you. If there was any question, we continue. Please.
Mədə rezeksiyası və subtotal kolektomiya etdikdən sonra ilyastomanı nə üçün qoyursunuz? Niyə bir momentli anastomoz qoymursunuz? Çünki xəstədə keşməzlik varsa, artıq keşməzlik götürülüb.
Anastomoz yapıldı bu hastaya. İleosigmoid anastomoz yapıldı. Hastanın ileus tablosuyla ameliyat olduğu için bir koruyucu ileostomi yaptık. Hastanın genel durumu çok
preventif koymuşsunuz.
Preventif.
Pardon.
He asked why we put a ileostomy for this patient, and I said this is a protective ileostomy. We make anastomosis for the Balkan chapter. I need to translate. This is our last case. This is our hardest case, and this is I want to say first. This is a failed case. This was a 55 years old woman who presented with weight loss and positive fecal blood tests. Her comorbidity was hypertension. She was 60 kilograms in weight. Family history included the uncle with lung cancer and father with brain tumor. In January 2016, colonoscopy demonstrated a tumor at splenic flexura and biopsy confirmed adenocarcinoma. PET-CT showed multiple FDG with hypodense lesions in both liver lobes. There was also intense uptake on the left abdomen, according to the splenic flexura tumor. Serum carcinogenetic antigen levels are elevated. What should we do now for speed? I think everyone says there is a proper patient for systemic chemotherapy. We started with systemic chemotherapy, neoadjuvant chemotherapy. After neoadjuvant chemotherapy, we can see the images now. Dr. Gonca, can you show us images?
Okay, so first the arterial phase. You can see immediately the bilobar metastatic lesions. I don't have the pre-chemo images, so we'll say it's stable. And here, this is a nice case for our radiology team. The splenic flexural lesion, it's unusual than an outward diffuse enlargement. It's a mucosal enhancement. We can see this because we have arterial phases. Because of I can see the mucosal enhancement better. This is a very nice teaching patient for my side. So looking back at the venous phase, here is the primary tumor, uptaking a little bit more. Some lymph nodes around it. And the lesions, you can obviously see bilobar in every segment. No aortic, periportal lymph nodes. No obvious ascites, no obvious peritoneal carcinomatosis. And for the lung phases, no gross metastases.
Thank you. Can we go on with my slides, please? The patient had disease control under chemotherapy, but the distribution remained bilobar. Patient was fit and young. The challenge was how to clear liver disease while preserving enough future liver remnants. There is two options, continue with chemotherapy or surgery. Please. Maybe we can show the image again.
But from the beginning, we need a liver-specific MRI.
No.
From biopsy. I think otherwise we cannot specifically. Okay, yeah, we can just assess it with CT scan. But sometimes we have seen a lot of patients where we see more metastasis on the liver-specific MRI, and we have to just check the chemotherapy response. It's always the ideal to make it.
All right, but
not after the chemotherapy, before.
You are correctly right, but this patient come from the other hospital, and when this patient come to our hospital, she already received her chemotherapy and finished her chemotherapy regimes, and this is our first image. Can we see again the image at
January?
The coronary plans? Can we
switch to my screen? So this is the January CT coronal images, surgeon-friendly images. I like that saying, Dr. Kaya. So as you can see there are multiple bilobar in every segment lesions.
How about Gonca, segment 4A and 4B?
Looks clean.
And segment 1.
Looks clean. Here we go.
These are...
Well, regarding this patient, MRI won't change anything, but the problem in Turkey is So our surgeons, because you live in Germany, it's easy for you to find MRI. But our surgeons and our oncologists, they love to do everything fast. So they cannot find MRI. They prefer to do it with CT. I totally agree with you. MRI has to be done always and always.
It has nothing to do with Turkey or Germany. I think we do liberally in Turkey a lot of PET CTs, which are not indicated in most of patients. Yeah. But instead, we just avoid to make a liver MRI, which is right now also in NCCN guidelines suggested. I think this is not a scientific explanation.
So in Turkey, as a surgeon, we almost want to take to the MRI.
And we just don't give you slots. That's the problem, because it takes long. This is the reality. This is the fact. No PET CT, no CT can outward MRI. MRI is the thing you have to do. If you want to see the exact tumor load, it's MRI, because diffusion will give you something else, T2 will give you something else, gadolinium mass, primovis will give you something else. This is the same thing in tumor boards. We say, let's do an MRI, and then they're not happy, and they say, okay, give us a slot. And it's a thing.
Doctor?
I don't see the reason and the place of the obstruction, but I see that the stomach is full of and dilated. So what is the?
This is the new patient. There is no stomach.
Oh, the
stomach.
The dilatation, like a sign of the high ileus, that you have sign of the high ileus.
No, the stomach is not a problem.
Yes.
But maybe just eight and maybe this is scan problem.
No, there's no sign for no. It's because the last minute we make patients to drink half of the last of the bottle.
Oh, good.
It's like
That's the reason.
The previous 2 minutes they drink it and go in. This is why it's the standard. It looks the standard, but there's no sign here in the CT.
Can we turn to Dr. Fatih? Please.
Okay. So this is a stable disease after 6 cycles of chemotherapy plus bevacizumab. So in this situation, I don't see any light still. Okay, we can prepare for an ALT procedure or hybrid procedures but I think we need to change the chemotherapy regimen, because if we have stable disease, and we will have a stable disease, nothing will change in terms of surgery. So I will talk to my oncologist to whether he or she is willing to change the chemotherapy regimen. For example, add irinotecan.
Yeah. This is an old patient about 10 years ago, but this can be option. You are totally right.
Old patient?
Yes, about 10 years old. 10 years ago, this is 2016 about she comes from this year. Can we turn back my slides? It doesn't work. This is not work. I can't continue.
Slide.
Okay. We prefer the make an ALPS procedure on June 2016. The patient underwent left lobectomy, segment 4B metastasectomy, and microwave ablation for 2 metastases in segment 4A and 4B. We know this was an aggressive approach, aiming for complete macroscopic clearance with rapid hypertrophy of the future liver remnants. We aim to hypertrophize the segment 4 and 1 for future liver remnants, and we aim to make these segments tumor-free. Here, the operative anatomy is demonstrated. We can see the segment 2-3 resection area, and we can see right hepatic artery, right portal vein, posterior stump, and anterior sector stumps. This is the dissection area between segment 4 and right liver. and we use plastic bag for avoiding or reducing the adhesions. Pathology is showed to multiple mucinous adenocarcinoma metastasis. And after postoperative 12th day, we measured the remnant, future liver remnants. Volume is increased to 328 cubic centimeters. But this volume is not enough for patients. So we elongated the waiting period. On day 18, future liver remnant volume is measured as 511 cubic centimeters. Now this volume looks enough for her. This is the CT image before the second stage of valve. The decision of our team to proceed the stage 2 and we make a second stage. We continue with second stage of ALPS and we do right hepatectomy for this patient. This is the remnant liver, segment 1 and segment 4. We can do ultrasound, intraoperative ultrasound also at this time. And we can't see any new lesions. After right hepatectomy, pathology is mucinous adenocarcinoma. Then the patient received 6 cycles of adjuvant chemotherapy. Unfortunately, about 1 year later, for liver surgery, image showed us recurrence in the liver and peritoneal metastasis. Maybe Dr. Gonca showed us new lesions and recurrence.
Can you switch to my screen? Thank you.
Please, Dr. Gonca's screen.
So this is the post-operative images. Late images. The new lesions have grown at the dome, and here you can see the resected areas. The left lobe has hypertrophied, the remnant liver lobe. And also we have this time a peritoneal carcinomatosis. We have densities and some implants regarding peritoneal carcinomatosis. This time in the lower abdominal images.
Thank you. Can we turn back my slides, please? Maybe some guys from our country know us. I usually not to try to present just the successful case. I always believe unsuccessful case is more educated for everyone. So I want to present this case for you. Once peritoneal metastasis and recurrent liver disease were detected, the treatment goal is changed. Curative surgery was no longer appropriate for this patient. Systemic therapy is the main option for this patient. After about 1 year, the patient had a lot of metastasis. Gonca, can you show us about 2019 CTs for lung metastasis? Can we turn back the last time to Dr. Gonca's screen, please?
Here we have a thoracoabdominal CT. Normally we look at the lung parenchymal window, but immediately you can see the mediastinal lymphadenopathies and parenchymal lung lesions. I will switch into the lung window as well.
Can you show like the lung?
This is the lung window, and you can see the bilobar progressed lung metastases and also mediastinal lymph nodes around.
Thank you, Dr. Gonca. Last time, please. The patient died at 2090. There was a 64 months between first diagnosis and death. This case reminds us ALPS can expand technical resectability. but the patient selection is an option. Maybe we can need to remember this word of Black Kiddy: biology is king and patient selection is queen. Good surgical technique may bring short-term success, but it usually cannot overcome poor biology in the long term. I want to thank you all for your patience.